Should glow green. We're set. Okay, should we get a good move on? Okay. Good morning. I'm Susan Sterrett from Virginia Tech, and this is Kelly Joyce from Drexel University. Thank you so much for joining us on this rainy morning. We were talking about how the DC metropolitan area falls apart at weather generally. So we really appreciate your facing down some rain. Let's see, we're delighted to have everybody here, and we want to have just a quick introduction. We would need to tell you the important things. For example, the coffee's over there, as I think everyone has found, and just to set up some aspirations for us as well. We've got our thank yous at the end, but I really want to note that we're very grateful to Virginia Tech for its support, to National Science Foundation for its support, and to Drexel University for all kinds of logistical support, including the website. Very briefly, we'd like to set some aspirations for this workshop. We have gathered together a group of people who are from different disciplines. We've got people who are computer scientists, we've got social scientists who are ethnographers, we've got healthcare providers, researchers, ethnographers. And people come from very different perspectives and we know talk very differently. So to encourage discussion, we want to make sure that we know that we agree on what we're trying to do and to come back to some common questions. And that includes that we really want us to think about theorizing how people and organizations frame their questions, produce data, and evaluate data validity and analyze problems as we think about moving in this new world of data analytics, and which is very large scale and requires collaboration, so that we can all aspire to more than what's in the cartoon, which is that after 437 charts and graphs, let's hit the liquor store and get snockered to decide. The logistics. Okay, so for timing, well, coffee and food's over there. The restrooms are out in the hallway over there. And then we have invited people who are speaking to talk for 20 minutes. And Kelly and I have agreed that we really believe in those kinds of time limits. And so we have cards, and we'll enforce it on each other as well this morning. Chairs will stop the talks at 20 minutes, and then we'll ask discussants to comment for about 10. We want to make sure that this is really conversational and we leave time for conversation. We also really are eager to be sharing food and coffee with you because we know learning happens in informal settings. So, Kelly?
So as many of you know, NSF invested recently, or a few years ago, in big data regional innovation hubs. They funded 4 of these hubs, the Northeast Big Data Hub, the South Big Data Hub, Midwest, and West. And this comes out of a prior commitment that NSF had to big data, and it will be followed up. Well, first let me say, the South Data Hub, we are very lucky to have Professor Aluru here today. He's going to talk to us about what they've been doing with the South Data Hub and also think about possible ways to collaborate going forward. So we're absolutely delighted that he could make it. Coming next in NSF funding will be the big data spokes. They've already just announced the first round of this funding, but there'll be 2 more coming up. So the big data spokes are supposed to grow out and be related to the big data hubs. There'll be money coming down the pipeline. The upcoming deadlines are January 12th, 2016 and February 25th, 2016. So we really hope that people at this workshop will use these informal in-between moments to network and think about possible collaborations and teams. Now, it isn't just NSF that's been investing in the big data work. Of course, the private sector, universities, many have been. And we've had a big data explosion. And not surprising, there's been a lot of anxiety about the unintended consequences of the creation and use of big data. These are just a couple of the headlines. The first is from a Science Friday episode, Why Machines Discriminate and How to Fix Them. Another NPR story, Can Computer Programs Be Racist and Sexist? Of course, these concerns about the unintended consequences of big data has even showed up on popular shows like The Good Wife. I don't know if anyone saw that episode, where they were very concerned about algorithms being racist and producing data that discriminated against people of color. As an example of these unintended consequences, Kate Crawford, who works at Microsoft, gave a wonderful example about the city of Cambridge in Massachusetts. They had developed an app called Street Bump that basically tracks your accelerometer and your GPS data as you're driving to track down when you hit a bump so that it sends a message so that the city can then go out and fix bumps. What happened, though, was this wonderful app, which was very clever, had unintended consequences, which is the people who did not have these apps, which tended to be the lower income and the elderly, were not giving any data. So their neighborhoods tended to be neglected. So this is one of the things I think that's interesting about big data. It's not that people are malicious or consciously thinking about creating these, it's unintended. And we then have to react. So part of the idea of this workshop is to kind of get ahead of the stream and be preventative instead of reactive. And in talking about this anxiety, of course, this anxiety is not just about the data produced by NSF's funding, not at all. It's about this larger stream of effort that has gone into producing big data in the United States.
One of the things we've been noticing as we've been getting more oriented in this field is that we shift around a whole lot in what it is that we're talking about, and so that we see this big expansion in what's going on with big data or all kinds of data or data analytics with new tools for analytics. And we think that some of that is making things more complicated, so that we've moved from business analytics, and those cartoons, many of the cartoons that I've used are from business analytics, where there are relatively clear success metrics. Are you making more money? Although the Wells Fargo episode points out some problems with that particular metric, to theorizing within social sciences why and how people and organizations do what they do, which is a very different kind of concern than how do we organize things to make sure that our business is successful. And there we do need to we do want to theorize how it is that people work, not least of which is it does end up explaining some of the Wells Fargo problem. I love the line from Upton Sinclair, if someone's living depends on not understanding something, they won't understand it. And then also we've moved into public decision making where we have multiple cross-cutting goals. I've been talking to people in some of the cities on the coast in Virginia, and they point out that they're concerned about equity concerns such as making sure that lower income people are included. They're also concerned about stormwater runoff and making sure that the streets are safe and manageable. And they're concerned about public participation. And those things don't all fit together so that we don't have one clear metric, and that can get to be really challenging. We also have noticed that there are different ways of thinking about ethics across professions. One way is grounding ethics in an individual, and that the analyst has to behave ethically, and then the concerns aren't broader than that, and that ethical problems are intentional, and that ethics are meant to be prescriptive to tell people what to do, and rules-based. And we find that that misses a few other things, such as intentional uses that the analysts don't necessarily put together, unintentional impacts, as Kelly was talking about, and harms to groups rather than individuals, and that we need principles to govern new kinds of problems with new analyses. So, for example, what is human subjects research, which we usually think of as interacting with human beings, if actually publicly available databases make people individually identifiable? A quick example of the intentional uses, but not by the analysts, is the North Carolina voting case where the analytics were actually very, very good at figuring out African Americans differently used, for example, early voting. And as well as different kinds of ID cards. So the North Carolina law, which has been held to be unconstitutional, actually targeted African American groups and forms of ID and forms of voting disproportionately used. Nothing wrong with the analytics, it was how it was used. Another way of thinking about ethics that we're really trying to facilitate in these 2 days is ethics as collaborative learning designed in so that we don't forget things. Example from the cartoon is all this effort into the analytics from dogs, and we left out cats. That is, cats are probably at least somewhat relevant to dogs as someone who has owned both. So we want to ensure that we ask good questions, that we always ensure that relevant data are included, and we believe that these require perspectives from multiple points of view, or multiple perspectives. That we want to understand the processes for using data and for producing it. We want to attend to the human costs of collecting data. It's not always free. And we want to make sure that we build trust, which is an issue differently distributed in the United States and by groups, and address inequities, and minimize the risk of collateral harm. So Kelly's got an illustration from a project of hers.
So I had the fortune to be funded with my co-PI, Chris Unsworth, who's about to come through the door, to study the ethics and values that are driving teams that work with with code and algorithms to produce big data. We did 3 field sites. We've completed the data. We're just starting to write it up. Now, this is probably not surprising what we found, but I think it's interesting and helpful to think about. So we did 3 different field sites. One was a team predominantly run by computer scientists that were trying to create a data set in predictive analytics that would recommend a health-related product to customers. Another was a very multidisciplinary team that was trying to develop a wearable technology that collects and analyzes data. And the final was public health researchers who were developing and linking data sets that organize and predict employee injuries. Now, and we did interviews with everybody affiliated with these sites. Now, what was fascinating, these were hardworking, great teams, but the disciplinary training and expertise of the people on the team really shaped the values and the output of their work. So it's not surprising, but it was interesting to see in the data. Computer scientists really were driven by issues of speed. How fast was that data going to come back? Elegance, was the code elegant? It is an artistic act to write code. And flexibility. Would the code be flexible so that going forward you could build and change and use it in different settings? They were concerned about data validity in human subjects, but they really hadn't been trained to think about how do you decide whether your data is good or not. And as an example of this, they were well aware of the pitfalls. So with the computer science team, I said, do you really think whether you smoke or not is going to predict whether you want this product or not? And they said, no, we know that's not really the predictor, but we don't know how to get that other kind of data. So they were aware, but they weren't trained to think about the kind of validity of the human subjects data that they needed to do good work. In contrast, the public health research, public health like social science and behavioral science are from day one on how to think about human subjects and the messiness of the data that they're working with. So this group right away understood that all the data on workplace injury probably had a lot of mistakes in it, and they spent a lot of time going back to the original data sources to straighten all those mistakes out. They also spent a lot of time trying to think about how to keep that data private and secure. That is what they were trained to do, and that is what they valued. They talked a lot about guarding the data. They talked a lot about data validity. Then they were trying to teach themselves code. Right? And then, so bringing that in. So in each case, the team was trying to make up for what they didn't have, and they were trying in the best way possible. But it was hard to do because they're not trained to do that. And I think we have to understand that, and I think we do understand, that as trained experts, we know how to do some things, but not everything. So then how do we take advantage of that and put those kinds of teams together instead of trying to do it all ourselves? Now, we're not naive. Susan and I, we've been around the block. We understand that multidisciplinary research is incredibly hard, and anyone who's done it knows. It is very challenging. Words fall apart all the time. You think you're all talking about the same thing, and you're not. Even simple words like ethnography or qualitative research or quantitative research can mean different things to different disciplines and stakeholders. And so for people who engage in multidisciplinary research, we fully understand you have to have a sense of humor, you have to be open-minded, and you have to be willing to speak up and say, I do not think we are talking about the same thing right now. And I am on multidisciplinary teams, as you can imagine. I actually enjoy that kind of stuff, but many people, it's different. It's different than how we're trained. So things are going to fall apart in this conference because we have people from such different perspectives, so we encourage you all to speak up and say, I don't know. I don't know what you're talking about. That doesn't make sense. That's not how I use that word. And that's how some good conversations will happen. The other thing that seems to be very challenging about multidisciplinary research is just the rewarding system is so different and the status of different disciplines. So for instance, if your discipline tends to have a lot of access to grant money, but another one doesn't, or another stakeholder doesn't, how do you kind of compensate for that? And then you also have to negotiate all kinds of things like who has access to PhD students, postdocs, what do you get rewarded for in terms of merit and tenure? It's probably not going to be for necessarily the same things as some of your colleagues if you're on these multidisciplinary teams. Okay, so it is very challenging. We're not naive. We're going to talk about those challenges throughout the course of these 2 days. But it's also incredibly rewarding. You can draw on those different kinds of expertise that we all bring to the table, whether it's the urban planner from the city, the social scientist, the computer scientist, the engineer, the doctor, the clinician. We can together make very different kinds of big data that has very meaningful impacts on society. And that is the aim. And I think NSF has always taken a lead on funding those kinds of research teams because NSF knows the power of bringing these different disciplines together. And so we hope that will continue with the big data spokes.
So we just wanted to revisit very briefly that we want to make sure that we're collectively asking what makes a good research question, and to appeal to Kelly's point, that we might be using those terms in very different ways or understand a good research question in very different ways. And who decides? And to really pay attention to how are data produced, since, again, we all know that data are messy wherever it is that you're doing it, and that data wrangling is the language that sometimes get used. I've heard data janitorial work, that's really significant, and that's actually not to the side, it's central to what it is that we're doing, and to understand that as a process. And who investigates, and how do we negotiate data validity and what we're doing with data, and how does that inform what it is we're trying to do? And how do we make sure that individuals and groups are protected? It's clear that in a rapidly changing environment, that the requirements for protection are also changing quite a bit. And because, for example, publicly available data sometimes make people more visible, both as groups, and there can be harm in that, or individually. And we know that the world has changed enough that people may or may not always be worried about it. And very briefly, the maps are from an article on geolocated tweets. I've enjoyed some of the computer science papers that I've gone to here at Virginia Tech, and so I was interested in geolocated tweets, and I was cruising around looking for that, and noting that this is a map of drunk tweets in 2 different cities, and so that they talk about being able to locate people's homes with a fairly high degree of accuracy, using input from Amazon Turk. And there's actually some good sociology on the production of knowledge out of workers in Amazon Turk. So that's just a quick question about what are the questions that we're answering, or that we're asking. What makes for a good research question? What is it that we're learning from drunk tweets? That's their language, not mine. I didn't make that up. But I don't think there's any part of my life where I talk about drunk geolocated tweets. But at any rate, how do we pick that apart? What is it that we're learning? What is it that we're asking? What are the data? And how are people protected? Go ahead, thank you. Oh, and how are we using our data and our models? And I think we can wrap it up on time. Kelly and I have been teaching a long time, and so we know about on time. We want to make sure that we have our thank yous, because we owe quite a few, and that includes National Science Foundation, our workshop grant. The numbers up there, and the program officers who were just stunningly helpful in their guidance, and that includes Hung Shu and Wenda Bachspies from Science, Technology, and Society. Virginia Tech National Capital Region Office has provided this beautiful facility and outstanding facilities support. If the food and everything works for you, it's going to be because of them. Mel Lanier, the graduate assistant, who I think you've all been in touch with, who did just an unbelievable job of organizing the logistics for this. And when I was getting sucked into departmental emails, one would pop up from her reminding me of something I had to do, which I could not be more grateful for. Julie Hudson, Virginia Tech, also Metropolitan Institute, also provided terrific support. Virginia Tech's ICEE has sent some people up from Blacksburg. Virginia Tech Foundation is paying for some wine at the reception. I want to be clear about that. No federal or state money. Irene Cho, who provided support and I believe organized the website at Drexel University. And then all of you, because we've learned from reading your work and paying greater attention to all the scholarship that's out there in this area. One more logistics thing I forgot, we are live streaming, and so if you would use your microphone, don't do what I say, not what I do. So if you would use your microphone in front of you, and if you push a button, it will glow green, and you will be able to ask questions, and then you can turn it off when you're done. So thank you very much, and we're really excited, and we invite the first panel up. Yes, ma'am. That's a great question. So we know that some people are interested in watching it for intellectual reasons because they can't get here for one reason or another. And that's the only use we intended to make of it. Does that make sense?
It's not going to be recorded. It's going to be
Yeah.
live streamed.
Yeah. Fantastic. Anyone else?
Any other questions before we?
Thank you all.
The first panel can come up. That'd be great.
Oh, there you are. Okay, that's all right. Hi, Susan. I saw you once in a meeting, and so I wasn't sure. Yeah, so okay, good. Thank you. Okay, good. I'm glad. Hi.
I think he just walked out.
Okay, good. So let's see.
Okay. Okay, great. I think we're up. Oh, okay. Well, good morning. I wanted to start by thanking Susan and Kelly for organizing this conference and Mel for all the work that she's done. My name is Justin Abel-Labreche. I'm an executive with the Internal Revenue Service. And from my perspective, this topic is extraordinarily important, especially as we seek to make more use of evidence in the way we develop policy and build programs, and also as we seek to make more data available to the public. It's really important that we're deliberate in our discussion and thinking about ethics, that we're intentional in designing ethics into how we deliver and build and use big data, and that we're constantly scanning for the unintended consequences that may lie behind how we use data as well. For the last 18 months, I've led the Office of Compliance Analytics in the Internal Revenue Service. We're primarily a quantitative test organization. We do a lot of experimentation around what types of interventions with taxpayers will improve their experience of the IRS, will help them be more compliant voluntarily, and help us recover revenue where appropriate. And so our big goals have been to make analytics pay and also to make analytics mainstream, to really spread the use of analytics across the IRS. And I wanted to share one thing that we've been doing to try to integrate ethics into our approaches. The IRS has a longstanding history of putting a lot of protection around data. But going beyond that, we've begun using low-income tax clinics and taxpayer assistance panels to talk to taxpayers and their advocates as we design interventions to be able to make certain we have a good understanding of the unintended consequences when we start to test things like collection notices, for example. So the panels I scanned the agenda look extraordinarily relevant, and I'm excited to chair this one. And time to move right on to the papers. I think our general practice will be for me to give a quick introduction for each speaker, and then each speaker has 20 minutes to talk, and then our respondent is Hugh, who I think has 10 minutes at the end to respond to the papers. So our first discussant is Dr. Michelle Rogers from Drexel University. And we had a chance to talk a little bit before we got started. Her primary research interests include how people use information technology in complex settings, focused on understanding the impact of clinical information systems on the work processes of healthcare practitioners. And I was excited to learn she'd also worked for the federal government in the Department of Veteran Affairs, getting at Patient Safety Center, working on applying scenario-based usability testing and cognitive work analysis to study how electronic medical records impacted patient safety. So without further ado, Michelle, I'll turn it over to you.
Thank you very much. Is this your watch?
It is not my watch.
Okay.
But I suppose I will take the 1 minute remaining.
Okay.
Let me find Alex.
So good morning. It's difficult being the first person to have to start your presentation with such great panelists. But I appreciate the invitation by Kelly and look forward to having a good discussion about what it is that we're here to discuss and address the questions that our organizers presented for us. So when I got the invitation, or when we talked about this workshop and what I could share, I remember these specific things from Kelly, or talking about the impact of healthcare data on work practices, and then why and how such information could be implemented in design. And my background is in, as was mentioned, my background is in engineering, in socio-technical systems in particular. And that's one of those terms, as Kelly talked about, that a lot of people use, and it means a lot of different things to different people. And so I say that I come from an engineering background, and so when we talk about socio-technical systems and understanding the impact of those systems on work, we are coming from a technical background. So the things that we are thinking when we mention those concepts are technically based. And so they are rooted and grounded in understanding how technology impacts work. We kind of operate using a person-environment fit model constantly, where we're thinking about, I think that did get louder, thinking about how the environment and the things in the environment fit the worker or the person that's under consideration. And so when we think about big data, and big data in medicine in particular, the reason that I'm interested in such a topic is that it's still largely unproven, but yet hospital systems, institutions are jumping in with both feet. And even though the concept tries to parse mounds and mounds of data from disparate sources, we try to discover paths that could be useful in problem solving. But as you remember from the slides that were just presented, there's always this concern about data validity and trust, in particular as we look at collaboration and how we do that across multiple people. So as an engineer, we look at the work that we do as a distributed cognitive system. So my training is in industrial engineering, and so looking at systems in terms of cognitive processes. And we understand work to happen across multiple agents. So the collaboration that's present and in medical environments, those teams are growing larger and larger. So the number of people that are interacting around a problem are growing. There's a stream of activity that's going on so that this cognitive system is not just operating in a vacuum on one thing at one time. It's a stream of activity that's happening. It's embedded in a larger organization. So the time where one executive could have power over the activity, the quality, the cost-benefit analysis of one entity is very rarely happening anymore because of the larger organizations. There are phases of ebbs and flows in people's activities, in their responsibilities. And there's a use of tools everywhere. So not only are you interacting with a wide variety of people, there's also data being generated in a variety of places through a variety of entities and across a variety of time and space. So the conceptual framework, as I talked about, that we consider is a socio-technical systems approach from an engineering perspective, so that organizations are complex systems of technology, people, and tasks, and that success or failure lies in understanding the interaction that takes place between those organizations, between those tools and technologies, between the tasks that they do and the environment that they operate in, given an organizational context. And we understand that this work system is impacted by these interactions. So over the years, there's been lots of study in how the work system impacts processes and how it can be manipulated or understood to impact processes. And those processes can be physical, they can be cognitive, and they can be social/behavioral. So we know that as was mentioned earlier, there can be some anticipated problems and there can be unanticipated problems. But one of the great things of all of the fields that we've studied in preparation for coming into the healthcare field, we've been able to know that while some things are unanticipated, they're not, while some things are unanticipated, they shouldn't be unexpected, right? So we know that there are certain things that go wrong that we should be able to impact. So now with this increase in data sources, this also impacts the work that clinicians do. I apologize, I got out of order in my notes. So from the patient side, there's loads and loads of data that's now being generated by sources that the quality, that the validity, that the reliability now can be called into question. So whether it be from a diabetes tracker, whether it be from a glucometer reading, patients now have access to data that they are putting forward to the institution or to the practitioner for use in some way. Clinicians now have access to more data and a variety of data whose quality, validity, and trust comes into question. And institutions also have to attempt to put a handle on what it is, all of this data that they're now coming into context with. So we have electronic health records. We have a need for digital, for decision aids and visualization in a way that will allow us to understand all of this data that we're being impacted by. Unfortunately, we're also at the same time being impacted by the fact that people with chronic conditions are much more difficult to manage, making them want to look to such apps. But it would be, or look to external ways to track their data. Unfortunately, there are, as of 2012, which is now probably double the amount, but there were over 40,000 health-related applications that people can download, that people can integrate into their lives. Now, there have also been recent studies, even within the last week, about how most of these studies are not having the impact that they thought they would have, but they are generating data, and what happens to that data once it gets generated. And the use of the internet to access health information, while it's low, most of the time it's tied to events. So how, as practitioners, how, as collaborators, can we use that for our benefit? As was mentioned earlier, multidisciplinary teams are now a must. It's no longer acceptable to operate in a vacuum. And in particular, in healthcare informatics, or in the areas of healthcare, we're looking at more than just clinicians that are involved in the management of data and in the use of data. So we're looking at computer scientists and psychologists, not only from social psychology, but also from organizational psychology. Graphic designers and industrial designers needed to design interfaces that support work, no longer work against what people do. And these multidisciplinary teams can no longer leave the patient, or whether you call them a user or a consumer, no longer can they be left out of the equation, so that the technical now has to talk to the social. So one very good example of how technology is in putting itself into the actual practice of work is in an electronic ICU. So there are facilities now where expertise can be sourced out or used, no longer being on site, but increase quality while also increasing job satisfaction. So in this location is an off-site electronic telemonitoring unit where you have clinicians of varying expertise levels that can offer support, they can offer monitoring, they can offer expertise about specific conditions and events that are going on within patient rooms or patient environments. So we're concerned about how is that data being visualized. The physical location of the screens can cause concern for the ergonomist in me, looking at how the screens are configured and how long they have to sit. What role does the interface design play? The organization, does this build or subtract from team communication, as they can talk to nurses that are physically located in rooms, but they're not physically located there? The complexity of these systems and the systems that they interact with, the safety culture that either this builds or impacts negatively. And as we look at these human users, how much is attention an issue as they monitor these screens? The physical ergonomics of them sitting in these locations for long periods of time. What role does fatigue play in them monitoring these screens and then having to act on what it is that they see? So the years of experience in engineering and in industrial engineering and systems engineering, we know that there are some there are unintended impacts of what people do, but they're not unanticipated. So that, they're not unanticipated. There are some things that we know people do when they get overwhelmed, when they get bombarded with loads of data. We know that they trade accuracy for speed. So if there's something that you have to do that is required for you to complete in a certain amount of time, we know accuracy drops. We know that there's performance criteria are reduced. So how does that impact the data that gets inputted or the data that gets used and how that data gets used? We know people deviate from procedures. We know they batch or defer tasks. We were talking last evening even about how now a lot of clinicians have to do their documentation after work hours. How does that impact the data that gets input and used for decisions that are made in the future? People shed tasks. They're just tasks they don't get done or get done at a time that is not timely for effective decisions to get made. We know they recruit additional resources. So in order for them to get their work done, they have to recruit additional resources. If those resources are not available, how does that impact the data that gets generated? And finally, we know workarounds are done. When interfaces are designed improperly, when processes are based on simplified understanding of work process, we know that workarounds get developed. Workarounds often introduce risks that people do not anticipate, which then can negatively impact our task, our error rates, et cetera, et cetera. So we know that these behaviors develop as a result of people being overwhelmed with data, with responsibility, with changing standards. So if we know these things happen, then it should lead us to limit the amount of unintended consequences, because we know that these things happen, so we should be able to anticipate them and design around them. And how do we do that? We can help people overcome the keyhole effect. So the keyhole effect, if you haven't heard, is how, so designers sometimes want to limit the amount of data that people see in order to make it more simple for them. But when you limit the amount of data people see, you also impact the decisions they make, because now they don't have a complete view of the data that they need. So you have to understand work in order to introduce filters or ways of decreasing clutter can also, in a way that you might not anticipate, it can limit what clinicians see. We need to integrate workspaces. We know that if we can integrate what clinicians see, that providing long shot displays, it can increase the way data is used, the way data is enhanced. Overview displays, allowing people to see how their work is impacted, how their work and how the data that they're receiving can play out in the decisions that they make. We can graphically depict data relationships in ways that help us make positive changes. And finally, we can aid in event detection. So there are ways that we can display data that help us find a solution as opposed to hiding a solution, or making a solution less effortful in order for us to find it. So one case example I wanted to just briefly share before I wrap up is about health information management in low resource settings. So there's still all the challenges that we have here in terms of large populations. There's a shift going on between paper records and electronic records. Who manages data? How do we ensure that data is reliable, that it's valid, and that it's timely in order for clinicians to make decisions? So we've been working on a project in Uganda for, I guess now it's been 3 years. Uganda is a country about 34 million. They have a fairly young population. 13% of which live in cities, but that amount is growing rapidly. So the number of clinicians that have to manage a lot of data and manage it in less than ideal situations. There is a main referral hospital, national referral hospital, I should say, in Kampala, the capital city. Mulago Hospital has 1,600 beds, over 3,000 staff members. So that's a lot of people interacting with data constantly, but not having the not having the advances that we have in terms of visualization, in terms of monitoring, in terms of long-term monitoring. And how do you maintain the necessary control over how data is stored, how it's accessed, how it's retrieved, how it is categorized. All of those things are very important. So in our project, we were able to just do a needs assessment, or an asset assessment, actually, looking at what assets do they have at their disposal. We know that there's a need to support current practices, in particular those within the system and those using the system. And this is only from the clinician side. We have yet to even get to the patient side. And we need to bridge this gap between traditional and modern practices. So we need to understand all of their infrastructure challenges. So not only broadband and Wi-Fi, but also power. How do we manage the data information availability? Human resource management and challenges. How do we manage and ensure that trained personnel are where they need to be and have the data that is accessible to them? So part of the project involved a resource of health information by the Global Library of Women's Medicine that was generated around by the International Federation of Gynecologists and Obstetrics. They provided a totally open source, totally free resource of clinical information to help clinicians understand and refresh their training. And how do we provide that information in a way that's timely as well as a way that's useful? There are poverty challenges, not only in technology, but also in training and cultural norms. What are the norms? How do you install systems? How do you support work practices that need support and need help? So we know we're challenged by several different factors. We know that technology can be used to support teamwork in terms of diagnosis, for example, or handoffs, or all of the variety of ways that data is exchanged and utilized. And it may be difficult to use tools such as decision support tools, things that help clinicians make decisions, if we're overwhelmed or have a data overload in the amount of data that's available to us. And privacy is always a concern, as well as the regulation and certification that's constantly changing here in the US. But we also know that there are potential and opportunities, that we can now track and manage conditions between clinical encounters, which has often been the lost thing, right? We're not keeping track of what happens in between your doctor visits, not just when you come in to healthcare. And we have the opportunity to use health communication practices, the best practices that are out there, and even social networking to enhance access and communication with healthcare providers. So we know that there are lots of potential, lots of opportunities, and I will end it there. And I guess we'll save questions for the end, right? Okay.
Well, thank you, Michelle. That was a great start to our day and very timely. Didn't even need the 1 minute sign.
Okay.
Our next discussant is Dr. Srinivas Alluru. He's a professor in the School of Computational Science and Engineering at Georgia Tech. And as we heard earlier, he directs the NSF South Big Data Regional Innovation Hub, about which he's going to talk today. His research interests include high-performance computing, bioinformatics and systems biology, combinatorial scientific computing, and applied algorithms. And it's a good start to our interdisciplinary collaboration that we go from an industrial engineer to a computer and electrical engineer. So with that, I'll turn it over to you, Srinivas.
Thank you. It's good to see it projected. So I want to thank Susan and Joyce for inviting me to this workshop. So my own research area is high-performance computing. And Joyce mentioned this morning that the focus of computer scientists often tends to be speed and elegance of code and things like that. It couldn't be more truer in my case, because in the high-performance computing community, we just live for speed. It's really the computing equivalent of driving sports cars. And we essentially use very large-scale parallel computers or supercomputers, which have these days more than 1 million cores, and that sometimes can cost upwards of $100 to $200 million. And what our community does is essentially try to use these best computing resources on the planet as of today to go after the largest scale problems in any area, because these problems don't come from computer science, but they come from other areas. In my case, a lot of my research is focused on healthcare, where we crunch large amounts of genomics data, metabolomics data, transcriptomic data, and so on, and try to look for signals such as signature for diseases, functions of unknown genes, and things like that. There is a lot that we don't know in this space, and in the next decade or two, I think the advances in medicine and the advances even in agriculture and other life sciences areas will probably be the areas that will make the most impact in terms of advancement of humanity's capabilities and quality of life. So it's really important that people who are well-versed in ethics and policy get into this at the very outset, rather than the technology goes one way and then eventually people have to catch up, and that tends to delay things and also leads to some uncomfortable things along the way. So I'm here primarily to talk about the National Science Foundation's big data efforts, in particular their work in establishing the big data regional innovation hubs. So this hubs project has actually started October 1st of last year. So as of tomorrow, it will be celebrating its first anniversary. And I want to briefly walk you through what these hubs are established for, what they do, and what they've currently been doing. And I want to offer our hub and also other hubs as vehicles for you to engage in the type of interdisciplinary collaboration that you seek. So briefly, NSF's vision in establishing these hubs is that they realize that in the big data area, no one entity has all the expertise. Typically, in many research areas, the research starts out in universities as academic projects, and then when there is enough maturity, then it moves to industry. Whereas in the big data area, the universities are not generating data. In fact, our students who go for internships at companies come back and say, you have no idea what big data is all about. And so the data is actually generated in the field. For example, companies like Google and Facebook in developing systems that interact with almost everybody on the planet, collect these big data, hospitals, healthcare systems, and so on. So they're not really even available often in academic settings. So one of the key goals of the hub is to essentially put multi-stakeholder partnerships together, spanning multiple universities, industry, nonprofit organizations, government, et cetera, and go after regional, national, or societal big data challenges. And the other thing is to get together as subsets of communities to set standards and share best practices, because without setting standards, we won't be able to share data or operate on it, and build and provide data resources. So a hub may decide to develop physical infrastructure to create data repositories for the nation and then try to make them accessible to everybody. Technology transfer. So one of the things that NSF realized was that after spending a lot of research in big data, a lot of that is still sitting in the form of papers and hasn't made much of an impact. So they would like to change that through the hubs. Education and workforce trainings is, of course, always an objective. And also, last but not the least, engage with thought leaders and develop public awareness and ease adoption of big data technologies, because based on our some of the not so savory elements of our past, there is mistrust about how the government will use this data and so on. So here is, in a nutshell, the NSF portfolio of big data programs. The research is supported by a separate program called Big Data, which was launched in 2012. The DIBS program supports the tool building. Then the NRT program supports training of graduate students and others. And then the partnerships is what is handled by the Big Data Innovation Hubs. So for the purpose of establishing these hubs, NSF went by the census partitioning of the country. So there are 4 regions: the West, the Midwest, the South, and the Northeast. So we're sitting in the South region today. And in each region, they established a hub through competitive proposal writing process. And I'll briefly go through the other hubs because others are not here. I want to make sure that they're represented a bit. But I'll go into more details about the South region. So the South, so let me go through each of these regions. So in the West, the hub is led by University of California, Berkeley, University of California, San Diego, and the University of Washington. In the South, it's Georgia Tech and University of North Carolina, Chapel Hill. In Midwest, it's Illinois, working with Iowa State, University of North Dakota, University of Michigan, and Indiana University. And in the Northeast, it's Columbia, with other partnering institutions like Penn State and so on. So what each of these hubs are expected to do is they're expected to launch these so-called spoke projects, which are nothing but multidisciplinary partnerships with a specific mission in a specific area, right? And NSF is running separate funding programs called the Big Data Spokes programs that you just saw recently, that you just saw in one of these slides by Susan and Joyce. And NSF wants to fund some of these spokes themselves, but they're also hoping that we can get funding perhaps from other agencies or maybe even from industry and so on, and try to launch these projects. And each region has its own focus. And I don't want to take too much of your time, so I just want to briefly talk about some of these areas of interest that went into the original proposals. On the west side, they're all looking at some common areas like healthcare and big data infrastructure because these are cross-cutting needs. But every region also has their own particular focus in certain areas. So as an example of that, the West is interested in natural resources, in particular water, given the drought situation in California. And if you look at the Midwest Big Data Hub, one of the key thematic areas for them is digital agriculture. And of course, there are other regions which are interested in agriculture as well. But given the concentration of people interested in agriculture in the Midwest, we essentially hook up people from our region to them so that we don't try to compete, but collaborate and cooperate on these things. And the Northeast, run by Columbia University, and they have emphasis in cities and regions because it's a very dense area with lots of highly populated cities, and finance, of course, given Wall Street and so on. So going into more details on the South Hub. The South Hub covers 16 states from Delaware to Texas, and it also includes Washington, D.C. as part of our region. So we get to claim NSF, which nobody does. So we have so far more than 500 South Big Data Hub members, and these members come from 59 academic, nonprofit, or government organizations. We have, out of these, 25 are industry partners, and we have every major university covered in these 16 states. So the way we manage the hub is that there are two PIs for the hub. Georgia Tech is the collaborating lead institution, and I serve as the PI from our side. My co-PI is Stan Ahalt from University of North Carolina, Chapel Hill. And then we have two co-executive directors for the hub, one at the Georgia Tech location, Renata Rawlings-Goss, and the other at the UNC location, Leah Shanley. And we try to put our institutional strengths together. For example, Georgia Tech is a formidable force in engineering, and UNC has a medical school, and they have strengths in coastal hazards and things like that. So collectively, we cover more areas than we individually cover. So the priority areas for us are, at the time of the proposal writing, we declared these 7 as our priority areas. But these priority areas can come and go as our members show interest in areas. New areas can be born and things like that. So we focused on 5 areas: healthcare, coastal hazards, industrial big data, materials and manufacturing, and habitat planning. And there are 2 cross-cutting areas. These are areas that will span the other 5 areas and many more that we talked about. One of them is the big data sharing and infrastructure. That's key to everything. The other one is economics, privacy, and policy issues, which is very much in line with the workshop today. So I want to go into brief details. Of course, these areas are broad. What does healthcare mean? What does smart cities mean? And it's just a lot of things, and we have to pick some things to focus. So here is I'll walk through a series of examples of what we are focusing. In healthcare, one of the things we realized was that the 16 states in the South are home to largest perhaps fraction of minority population in the country. We have a large number of African Americans, also Hispanics, with the inclusion of states like Texas and others. So one of the things we wanted to focus on is genomics and other areas of precision medicine for minority population. And there is also significant health disparities in the South. For example, in a multicultural city like Atlanta with different lots of ethnic groups living, same hospital system, same doctors, sometimes same insurance, but the health outcomes seem to be different for different populations, and why, that's one thing we would like to study. And there is a 11th southern state region, which is called the stroke belt, where the incidence of heart attack is higher than the rest of the country. So what are the reasons for this? So we want to understand these things through data analysis. The coastal hazards, we have a long coastline that's part of the South region that includes both the Atlantic and Gulf Coast. So we have more than our fair share of the natural hazards, so studying those and trying to develop solutions is one area. Then industrial big data. This is essentially sensors and other things that collect information from machines like turbines, jet engines, and so on, and then the machines communicate, the sensors communicating with the Internet of Things, and so on. And how do we analyze the data that's collected from those? Because the South is a hub for power generation and utility companies like Southern Company. Oil and gas production is big in Texas, Oklahoma, and so on. So we wanted to look at the energy side of the Internet. Materials and manufacturing, Southeast is a manufacturing hub. US supply chain largely runs through the South, so looking at the gap between material science and manufacturing practice. So in this area, we are working with several government-established organizations like the State Manufacturing Extension Partnerships, also working with industry to see how we can take big data practices to industry. And then there is, of course, work on developing standards, developing infrastructure, and developing repositories and so on. And then the ethics and the economic modeling and security, privacy, and policy issues of all the projects that we are undertaking. So one of the ways that you could use this hub and other hubs is as a mechanism to identify some of the large-scale, impactful big data projects that are happening in the nation and get in the game in terms of understanding the projects and debating the ethics and policy surrounding that and helping these projects, because there is not a lot of collaboration today between the people who work on the technology side and people who understand the policy and ethics and other important aspects of this. So certainly, I would like to offer South Hub as a mechanism for helping such things, and I'm sure my counterparts at other hubs would be equally happy. So what can the hubs do? So NSF did put significant amount of funding in the total hub project, which I'll show you fairly soon. But per hub, this funding is not significant. So what we try to focus on is that communication services, matchmaking, where we try to put teams together, and seed funding for such activities, and then infrastructure services, and so on. And one of the things that we are trying to do is to piggyback on the existing infrastructure at the institutions to be able to make that money go farther than completely doing everything by the amount of money that's given, because that would be difficult. So at Georgia Tech, what we are trying to do is we are trying to create and host data repositories for the region and the nation. And we also have a unique resource in terms of a nonprofit called Southern Crossroads, which actually contracts its work to Georgia Tech. And it has the biggest pipe for delivering data. So if you want to send huge swaths of data, like petabytes, across the South region, it has to go through Southern Crossroads. And they're located like a couple of miles from Georgia Tech. So we are taking their services in order to be able to move data to and from partners and so on. And we have a deep bench of intellectual resources in various aspects of data science and engineering. My colleague Kay Husbands-Feeling is here. There are other people. She's the chair of the School of Public Policy. We have people who do economic modeling, and we have people in all areas of engineering and sciences and healthcare that big data touches. And then we are also trying to help our partners in these 16 states connect with the vibrant Atlanta industry so that the local industry can benefit from remote expertise and vice versa. So talking about investment so far, the hubs were launched at the end of September last year with a total investment of $6 million. So each hub got about $1.5 million. Within a few months, $1.2 million were distributed to the 4 hubs, so everybody got $300,000. And this is for nurturing academia and industry collaborations. And this funding came through an entity called Computing Community Consortium, which is part of the Computing Research Association. And then just yesterday, NSF made announcements of the Big Data Spokes funding for this year, and they granted another $11 million. And this went into 10 spoke proposals at $1 million each, and roughly about 10 spoke planning proposals at $100,000 each. And then this program is very likely to run again next year, and maybe beyond if the if the funding can materialize. So the way it works is that the hub is not owned by any singular institution. The way it is viewed is that the hub is coordinated by 1 or 2 major institutions. So in the South case, the hub is coordinated by us at Georgia Tech and UNC, but the hub really belongs to everybody. For example, Virginia Tech has been a significant partner in the hub, and they have been on the PI team for the hub from the beginning, and there are lots of interactions and so on. So the spoke proposals essentially go by teams of people from the region, and they go with the blessing of the hub, but there is no affinity to hub institutions. In fact, they would like to spread the money around as much as possible, of course, subject to the merit review of these proposals and so on. So what we've been doing in the South region is that with the $300,000 of money that we got to facilitate industry-academia collaboration, we did three types of things. One of them is that we identified students and sent them to data-related startups so that we can engage with companies in their early stage. And we also sent researchers and early career faculty and young researchers to industry, where we pay the money for the internship rather than the industry. And we're just trying to do matchmaking. And the idea is that this researcher goes and spends time at the industry and then comes back with a set of problems that they should look at, and that will lead to hopefully long-term collaboration. And as we started doing this, some of the companies came back and said, hey, we would like to take additional people with our own resources. And that helped us expand the scope of this program. And last month, we ran 3 industry academia workshops at Georgia Tech, one in health, one in energy, and one in materials and manufacturing. In each of these areas, we essentially brought industry to come and talk and faculty to come and listen. And the idea is that if the industry presents challenges and what are the things where they want help with, then the academic research can be directed towards something that's to meet the practical and needs and so on. And these meetings are very well attended. So for example, the health meeting, which we just ran 10 days ago, had about 70 to 80 participants, and which is fairly good number there. And we're hoping that these meetings will help put together teams that we are aspiring for. So NSF is providing spoke funding, and each spoke will address one of these 3 key themes. Either they go after a grant challenge, or they talk about how to share assets, right? So you may say, look, I'm going to bring assets in this domain from different entities and put them in a common format, build a repository, and make them available, or automating the discovery and maintenance of data assets. So what we did in the South region was to have a meeting last December, which 220 of our members attended, and we hashed out 68 potential projects. Then we went through a local filtering mechanism and identified 31, and we submitted these to NSF in the form of full proposals. So nationwide, they funded 10 of these spoke proposals. 3 went to South, 3 went to Northeast, and 2 went to West and Midwest each. And in our region, one of them is in the medical informatics and healthcare area. You can see that it's a highly collaborative project engaging multiple institutions there. And we have one in environmental sustainability using the IBM Watson technology. It's a partnership between Smithsonian, Georgia Tech, and IBM. And a third one on energy in the smart grids area led by Texas A&M. And so these are the 3 funded proposals from our region. So you can get more information about us by going to southbdhub.org. There are similar websites for others. So please consider joining the hub for your region and use this as a mechanism for collaboration. And before finishing up, I just want to show you what we are doing at Georgia Tech. We are investing in a $375 million building, completely devoted to data science and high-performance computing research. I co-direct an institute for data engineering and science at Georgia Tech, and this building will be the new home for that institute along with others. And what we are trying to do here is to bring people together physically so that they can interact. So the idea is that we have thematic floors where maybe a floor is focused on healthcare, a floor focused on business analytics and policy and energy and so on. And then we embed data scientists vertically so that they're kind of, the institute has a vertical presence. And then there are areas of computer science which are crucial to data science, like machine learning, high-performance computing algorithms. They'll take up horizontal presence so that everybody gets to live in one building. And then we can promote interdisciplinary research in data science. And again, you're welcome to take advantage of these resources. And we expect this to be ready in 2.5 years or so. Thank you.
Srinivas, thank you very much. That was a great overview of the big data hubs, and the southern one in particular. And I can't wait to be invited to this building. Looks amazing. Our final speaker is Etta Davis from Fairfax County Government. And we're going to see another part of this interdisciplinary aspect as we transition from our academicians to our applied county government.
Right.
So, Etta?
Yeah, thanks. Yeah, now for something completely different. Is that from Monty Python? I don't know. I am not technically savvy, so I'm not sure if I know.
Yeah, so I think that's you.
That's me, thank you. Look again. Sorry.
Oh, no, I'm not. I'm a Mac person, so I'm not sure.
That's good.
And I think it'll give you your notes right there.
Yeah, perfect. Okay, great. So I am coming from a practitioner's perspective. My background is I've been working at the county for about 15 years. I've been doing, as I'm their economic initiatives coordinator, and that's been my role for the past couple years. Before that, I worked in Silicon Valley. I worked at a startup that got big money and imploded. So that was like a really cool experience. I had that experience. I worked at Gallo Winery for a while. I worked in DC for a while for a nonprofit doing international development. I'm sorry I didn't pass it. You guys don't have my background. I have a bachelor's from Tufts University in International Relations and an MBA from UC Berkeley. So I've been educated by a lot of academics, but I don't talk like an academic. So hopefully, hopefully this talk is going to make sense to you and it's going to be helpful. I've been working closely with Adam Eckert, one of the professors here at SPIA, and I saw the list of people speaking and the topics, and I said, "Are you sure this is you guys want me?" And Adam's like, "You need to hear from a practitioner." I'm like, "Okay." So I'm just going to have faith that this is going to be helpful to you. Basically, I'm going to tell you about our economic success plan, which was adopted by our Board of Supervisors in Fairfax County in March of 2015. It was the first time we took a really broad interdisciplinary look at what we are calling economic success versus economic development. We have a long established, very well-respected economic development authority in Fairfax, and they do very traditional economic development work with very traditional economic development metrics. And we decided to take a broader look. Sequestration hit us hard. There's been a lot of changes in just how people use space. And basically, the way it works in Fairfax County, all of our money comes from real estate taxes. And if we've got high vacancy rates, that means we've got less money coming in. And perhaps many of you have experienced the changing use of space. There's more people are having a smaller footprint of space that they're using. There's more collaborative space. People are teleworking more, and that trend is not going to change. So that has a direct impact on our bottom line. So we have to think differently. And there's a lot of other things happening as well. There's growing income inequality. There's the changing kind of the way industry is working is having an impact on the population at large, and certainly in Fairfax as well. So we kind of took a look at what are our goals over the next 5-10 years, and this is kind of what we came up with. The first goal is to further diversify our economy. So there's 92 actions in there. I'm not going to give you all of them, but I do want to give you some context. So we've got actions in there around how do we grow research and development in the area, how do we partner with universities for them to grow their footprint here in the area, can we build an innovation ecosystem, can we grow our innovation ecosystem, can we create an innovation district here in Fairfax. I mean, a lot of people talk about innovation districts, and it was actually very interesting to hear about what's going on with the National Science Foundation. We looked at our development process, the way we work with our development industry. They've been complaining that we're losing, we're at a competitive disadvantage here in Fairfax because our processes are too slow. So it might not seem very strategic, but the development industry's got a lot of money, and so this has got actually a very high priority to look at how we improve our processes internally within the county. Our goal 4 is around investing in natural and physical infrastructure. And then our goal 5 is achieving economic success through education and social equity. We put that directly as one of the goals of the plan. We actually got a lot of pushback when we were first considering putting this in the plan. We have a lot of I don't know how to say it more tactfully, but a lot of the decision makers, are the commission members and the people we work with, kind of skew older, white, male, and kind of establishment. And so when we talk about equity, they say, well, that's very nice, for human services to work on that stuff, but that's not really an economic issue. We're in trouble here. We need to focus on, development review process. But we really tried to make the argument in economic terms. And we talked about how how equities is a superior growth model, and we've talked about how it actually helps us with Goal 1, diversifying our economy. When we're kind of viewed as a progressive place, then it attracts. There are some startups in Fairfax, and a lot of them didn't pay any attention to us until they saw that we had equity as one of our economic goals, because they're like, oh, you're thinking about that? I'm thinking about that. I'm thinking about how to partner with the schools and get more kids involved in coding, So that it actually, so we talk about it. We talked about it in that sense, and the human services folks who have been working on equity issues their whole career, 30, 40 years, they heard us talking about it in this way, and they're like, I feel like I made a deal with the devil working with you guys. I'm like, just don't worry about it. We'll try to talk about it in a language that people can understand. And then increasing agility of county government is our 6th goal. How do we how do we internally in government be more agile, quick on our feet, the same way that the workers out in the world have to be now? So that's what we're working on. And so one of the goals is, how do we measure success? How do we measure that we've reached those goals? This is not traditionally the way we've talked about things. Or, we're not used to, like the public health folks, for example. They're very adept in measuring, period, while the rest of us, it's not something that's very kind of rich and deep. There's not a lot of knowledge on how to measure those things. So we partnered with Virginia Tech, and we had some conversations with Adam, and we really just liked the way he asked questions and thought about things. And so we've asked him and his team to kind of come in and to talk to a wide group of stakeholders, because we met with multiple number of people. I'll just kind of go through the process a little bit. They've helped look at patterns of similarities and help us kind of figure out what our measures are. So these are, for us, this is all probably very basic stuff for you guys, but for us, this is not the way we're used to thinking. And so now this is all kind of ingrained in my head, but I remember the first time I heard Adam talking about it, it was aha, So I just want to kind of put out to you, this might all be kind of second nature to you, but there's a lot of people out there who really could use your help. So it's just kind of, just the very basics are helpful to us. This is our America's Next Top Model jurisdiction, just kind of an example. So we did a lot of comparing ourselves with other jurisdictions as well. Kind of had to mix it all up together and come up with our own Fairfax brand. So for us, what we needed the measures to be was to really be a galvanizing force. We wanted the measures to be a key part of the message. When we're talking to our stakeholders, when we're talking to the nonprofits, when we're talking to the businesses, a lot of the goals in the plan, it's not something that we can do on our own. It has to be something that we partner with other areas and other, So, like for example, we had a meeting with the Chambers of Commerce, and we said, we had a conversation about the measures, and at the end of the conversation, they said, you know what, we can take those measures, we can put it on our masthead, we can work towards those goals. We had discussions with some of the nonprofits. We have a Child Opportunity Index. Is one of the measures that we've been using in our conversations, and the nonprofit said, you know what, I'm going to use that Child Opportunity Index, and I'm going to use it to target our programs. So we're going to use those maps to figure out where we're going to serve certain parts of the community. So that's what we need. That's what we need the measures to be, to actually be something that's influencing our policies and our programs. So, and yet also reflect the goals of the plan. Again, we had a lot of pushback, and I'm just going to go to the next slide. We had, to talk about some of the political realities, we had definitely some pushback where, we were throwing out measures around health and equity and, air quality and those kinds of things. And again, the politicians were like, so how is that economic success? We had to remind them, these are the goals of the plan. This is why it's important. I guess what I'll tell you is, we had people who gave us the Silicon Valley measures, for example, and they said, we want to be like Silicon Valley. We want to look like them. We want our measures to look like them. And so we have to find that balance. We've got folks that just get tired of talking about measures. I have people who tell me, if we're talking about measures one more time, I'm not coming to this meeting. I refuse. So. Yeah, and then there's some people who have like these sentimental favorites of these measures that they don't want to let go of. And also I wanted to tell you a little bit about the difference between working with consultants versus academics. There's a lot of generally politicians like the glitz and the glamour. When we work with consultants, they come up with these really beautiful, fancy, glossy magazines, and they're kind of packaged in a soundbite, and they can throw in throw in front of a newspaper reporter, and working with Adam, he's a self-described. He's like, I'm just going to come up with more problems. I'm just going to ask more questions and make it more difficult for you, and but also he's more likely to take the time to go in depth and to be willing to play the devil's advocate and say these measures are not good for these reasons. This is why you don't want these measures, and to kind of push that conversation. So it's been difficult to kind of find that balance sometimes. Sometimes it's been like I said, you never underestimate the intoxicating power of good graphics. You want to make sure that the politician can sell what you've got. Like I don't have it in this version of the presentation, but just a few days ago there was a report that came out. The governor of Kansas had done this big push for their metrics and had been using it as a political tool, and they had to. And there was a big newspaper story in Kansas that they pulled their measures off because it wasn't telling the story that he wanted, because his opponents were using it as a tool against him in a re-election campaign. The governor had done these huge tax cuts and was hoping it was going to stimulate the economy, and all the measures were showing the opposite. So he pulled it. So the measures are gone. They disappeared from the website. So we don't want that to happen to us, because we want these measures to be the plan to really kind of be pushing forward the agenda of the plan. And again, we want them to evoke an emotional response. So we traditionally in Fairfax have had this process of having just like tons and tons and tons of measures, and we need to have kind of a short, tight list. You talked about the keyholing, and there is that risk where if you kind of look too tight, there we might be missing information, but otherwise no one's going to look at it. So I don't know if you're interested, but so we kind of went back and forth on determining what kind of approach to use. I'll talk a little bit about, so this is, maybe I'll kind of show you the summary page. I won't show you all the measures. I don't know if you're interested. But these are the measures that we came up with. One of the things I'll talk about is the kind of the difficulty of determining measures just in general around all these things. In particular, we spent a huge amount of time talking about the innovation economy and how do you measure an innovation economy, and how do how do you do it in a way that you're not just being like Silicon Valley? For example, I just went to a conference that just got back yesterday from the International Economic Development Council, and they are all thinking about the exact same thing. Everybody wants to have an innovation ecosystem, and how do you measure that? So we're throwing around the idea: can we come up with an index? There's a number of different indices out there, but should we create our own? I will tell you that it is a trend with other jurisdictions around the country who are coming up, who are kind of making that connection between some of these same concepts in their strategic plans, and they're all throwing their hands up and like, I don't know how to measure it. I don't know how to measure placemaking. How do you create a place where people want to be? So this is definitely not just a Fairfax thing. It is a nationwide thing where people are struggling with how do you measure these things. And I definitely agree that it's important to have these interdisciplinary teams. Like I said, we have some public health folks in there in our team, and so they ask questions like, well, what's the theory of change? And we're like, theory of change? Well, what do you mean? What's the theory of change? And then we've got the business folks who are saying, you need to focus on this, and then we have got the public affairs people who are saying, I can't sell this. I can't sell a list of, 5 pages long. You need to have this tight message. So, so that's definitely something that is a trend as well. I don't know. So the next steps is figuring out targets for us and identifying what our goals should be, and that's where we are. And hopefully I didn't miss anything, but that's it.
Thank you, Etta, for providing that practitioner perspective. We appreciate that as well. And I think at this point, we're turning to our respondent for 10 minutes, and then we'll open the floor to questions. And our respondent is Dr. Hugh Gusterson, focusing on the interdisciplinary study of the conditions under which particular bodies of knowledge are formed and deployed, with special attention to the science of war, and how to analyze the historical and structural transformations in science and technology, particularly relevant for today.
Great. Thank you very much. And thank you very much for inviting me to be here. As discussant, I have a bit of a challenge in that I only got one of the presentations ahead of time. Thank you very much, Etta. I appreciate that. So given that, that issue, I think rather than try and respond in detail to the presentations, I'm going to give you my own somewhat random thoughts on the overarching theme of this session, which is good questions and useful answers. And I'm mainly going to focus on negative issues, problems I see in the world of big data, which you shouldn't take to mean that I don't understand all the wonderful things that you can do with big data. I'm well aware that, for example, in tracking energy usage, it's really useful for utility companies to know what particular kinds of times of day people are using most electricity, in which neighborhoods they're using them, and so on, how that correlates with weather conditions. Some of the stuff that we heard earlier about medical applications, searching enormous medical databases for correlations between genetic makeup and epidemiology, particular kinds of medical syndromes. And something like what you can do with Google now, where epidemiologists have found that the most useful way of finding a breaking epidemic is actually to track people's Google searches for particular medications and so on. And you often know where flu is breaking out best by searching Google searches rather than by relying on the data that you get back from doctors, which takes longer to come in. Or traffic applications to find the best way, the quickest way to where you're going, though I have to say this failed me today. Google Maps told me it would take me 36 minutes to get here. It took 65, so not infallible. So I come at this as an anthropologist who studies the military, and we haven't actually heard anything so far really about military uses of big data, but the military and the intelligence agencies are some of the leading institutional pioneers of using big data. They want to find bad people so that they can kill them or incarcerate them, and that's one of the main uses of big data by the Pentagon in Iraq, Afghanistan, Yemen, Somalia, the tribal borderlands of Pakistan and so on, and the intelligence agencies. And in tracking what they're doing, I've been struck by some of the dysfunctionality of the military and the intelligence community's use of big data. So, for example, I just published a book on drone warfare. And one of the things I discovered doing the research for that book is that when the military seeks targets to kill with drones, they often don't know who they're killing. They're cell phones rather than people. They have a list of cell phones on which at some point they've heard insurgents talking. And so there may be a cell phone on which they heard an insurgent 6 months ago, and suddenly a drone today. It's been inactive for 6 months, but on the ground there's someone on that cell phone. And so it's US military practice to target the cell phone and kill the person holding it. And this is one of the reasons why drones have killed so many innocent civilians, which is the limited data where they're looking for the and don't know precisely who's holding them. There's a military program called Argus where they've tried to stitch together footage from all the different drones so that they have absolute total information about what's on the ground. They would see every car on the ground and be able to rewind a car that had someone who planted an IED, where was that car earlier, and so on. And they've kind of given up trying to make this work because there was so much data saturation that they couldn't find things in the data. They couldn't stitch together the seams of different drones' footage effectively to get the kind of all-encompassing view that they wanted. And I've also been struck by the kind of data that people at the very top in Washington are getting from the ground. And it's clear from a number of people who've been writing about the campaign in Afghanistan that people in Washington, decision makers in Washington, think it's going a lot better than people fighting the war on the ground because of the metrics that they're getting. And this is familiar to anyone who followed the war in Vietnam, where generals and decision makers in the Pentagon were reading big data numerical indices that suggested that the US controlled territory in Vietnam that it did not control. So I always make my students in my methods class read a chapter of Daniel Ellsberg's memoir, Secrets, in which he went to Vietnam. He was sent there by McNamara to find out what was really going on. He got on a motorbike and he went all around the villages of Vietnam trying to figure out what was going on the ground. And he found that all these villages that were shown on Pentagon maps under US control were actually under Viet Cong control, certainly at nighttime and many other times of day as well. So this is to put a little plug in for my methodology, which is qualitative ethnographic methodology. Sometimes it shows things when you actually visit villages, you talk to people there, you ask them, are the Viet Cong around? What's your relationship with the Viet Cong? You find out things that the big data don't show. And one of the reasons the big data misled the Pentagon is that junior officers in the field knew that their chances to get out of Vietnam, to be promoted, were contingent on it looking as if things were going well in the areas that they were responsible for. And so they were, let's be charitable here, putting the best possible gloss on the data that they were feeding the Pentagon, interpreting it in the most positive possible way. And the sum total of this was a very inaccurate picture. Okay. So what I want to do in the remaining 5 or 6 minutes is to just flag 6 issues that I see in the world of big data. The first has to do with distorted input data, and we heard some of this in the prefatory remarks. There may be limitations in what you can capture. So the speed bump example, where you want to know where the potholes and the bumps are, but there are certain people, certain demographic groups that don't have the cell phones with the app. And so their neighborhoods are going to get left out. With epidemiology and illness, all those people who don't have health insurance, their health problems may not end up on the map, right? I've been interested in this recently in terms of opinion polls for political campaigns. Pollsters are very concerned that millennials with cell phones get left out of the polls. People don't know their cell phone numbers. You're not supposed to call cell phones when you're doing a survey. And so there may be entire demographic categories that don't get captured by the pollsters. I know that I, on principle, hang up when a pollster calls me. So I'm in a demographic category, the ornery, I guess, that doesn't get captured. And you see the problems that you can find here in the recent Brexit vote in the UK, I think. The polls clearly showed that Brexit would lose. And it didn't. So what was going on there? What we now think is that when pollsters approach people who were planning to vote for Brexit got this sort of elitist vibe from the pollsters. They thought that the pollsters themselves were against Brexit, and they felt embarrassed to reveal to the pollsters that they were planning to vote for it. These are working class white people in northern England in particular. And so the polls completely failed to predict what would happen. And I'll go on a limb here and I will predict that the polls are not adequately capturing Donald Trump's support, because I think a number of Trump supporters will get a vibe from pollsters that the pollsters are against Donald Trump, and I don't think the polls around Donald Trump's appeal are accurate. So that's one issue, sort of distorted input data. Another issue has to do with quirks of measurement, where the numbers may be accurate, and yet they're accurate but wrong. And let me give you an example I'm involved in at the moment. My neighborhood in Bethesda is trying to stop the development of 18 new high-rises in Bethesda because of a traffic nightmare that we believe that it will cause. Now, 4 or 5 years ago, the traffic got much worse in Bethesda when they unified the Walter Reed Hospital and the Bethesda Naval Hospital. And anyone who lives in our neighborhood will tell you it takes twice as long to drive anywhere as it did 5 or 6 years ago. However, they have done traffic studies, collected big data, and those studies uniformly show that after they increased the size of the Naval Hospital, they doubled it, traffic actually improved. And so local planners tell people like me that we're just whiners, and the data objectively show that the traffic has improved in recent years. As far as we can figure out, what happened there is they have wires across the road that measure how many cars move from A to B in a 10-minute period. And the traffic got so bad that the number of cars that move from A to B in a 10-minute period went down because the traffic is gridlocked. And they tell us there are less cars on the road. So you get these kind of quirks that you have to pay attention to. 3, the categories that you use. And I want to respond to something in Etta's talk. She skipped over a slide there that showed by racial category how people are doing educationally in Fairfax County. And I was struck by the categories that were used there: Black, Hispanic, Asian, right? Those are categories that don't always match people's subjective sense of racial identity. I have many students in my classes who refuse to self-categorize that way. They say they're mixed and they want the mixture in there. The American Anthropological Association recently successfully persuaded the Census Bureau to change its fundamental question around race so people can self-categorize and can be mixed race. So you have to be very careful about the categories through which you're straining this information. Okay, a few more things. What don't big data illuminate? I write a column, an online column for the Bulletin of Atomic Scientists. I'm amazed that my editor can tell me how many people opened it, how many people, how long they had it open for. He recently told me that Noam Chomsky opened my column for 7 minutes. But I don't know what Noam Chomsky did in those 7 minutes, right? For all I know, a grad student came in just after he opened it and spent 7 minutes asking a question about syntax. And he never read it. He just closed it after the grad student left. Maybe he read it and he loved it. Maybe he read it and he hated it and said, I'm never opening one of his columns again, right? So I know he opened it for 7 minutes, but it doesn't tell me what I want to know about Noam Chomsky in my column. So Sam Ladner says that big data often produce culturally illiterate product, right? So it doesn't get at meaning. That's where you need qualitative work. Okay, final 2 things. Medical data can tell you likely outcomes of particular treatments. But I think of my mother-in-law who had kidney cancer. She went to the doctor, should I have my kidney taken out? Should I have an ablation? I'm really old. Should I just let it play out? And the doctor said, okay, well, I have all this big data. The percentage chance that you'll die in 5 years this way, and this way is so-and-so, right? But that didn't really help her. She wanted to know, what should I, Pamela McFarlane, decide to do at this particular moment? What will be the side effects for me if I take that medication with my body? And the doctor really couldn't tell her. He just gave her these large statistical probabilities that left her more confused than ever. And in the end, she did what seemed like the best statistical thing. The operation went wrong, and it had very fateful consequences. Okay, the final thing I want to bring up is the issue of recursivity. So when we gather big data, we're not just analyzing for the fun of it. People look at that big data and they make decisions on the basis of that big data. They may be government agencies, the Pentagon, deciding who to kill and who not to kill. It may be utilities deciding whether to build a nuclear power plant or not, right? And it may be ordinary consumers deciding what route to take to drive to work. So think of something like Waze, right? You look at Waze and it says, look, there's this cool route that no one is using that will get you to work 10 minutes earlier. And before you know it, everyone is on Waze and they're all driving this cool route. And suddenly it's not 10 minutes quicker, it's 10 minutes slower, right? So you have these sort of path-dependent outcomes where as people thread their way through the big data, it actually changes what's being measured. Thanks very much.
Thank you for that additional perspective and compelling final thoughts. So I think we're open to question. Susan or Kelly, is there any guidance for the questioning? Should they use the mic? Should I give them a mic up here? How should we do this?
But yeah, if you just press the thing that has a graphic of somebody speaking, then it'll turn on and you'll see the light come.
Okay, great. Well, I'm going to hand the mic to you and pass it amongst yourselves. Are there any questions for our speakers today or for our respondent?
Yes, my name is Kelly Moore. I'm a sociologist from Loyola University in Chicago, and this is a question for Dr. Aluru. My question is, you mentioned in your talk that one of the things that the big data centers are doing are creating standards, and they're also in developing, I presume, standards not only for collecting the data, but also for sharing the data. And I wonder if you could say a little bit more about how that's being developed or some of the directions in which you're taking this kind of data sharing.
Thank you for the question. So the list that I showed you is kind of like the broad charter and the vision or the dream list, if you will. Mm-hmm. And we've been in operation for only 1 year. So we haven't really succeeded in setting standards or sharing practices in a specific area yet. As you can see, the spoke proposals just got funded yesterday, which are what are expected to drive some of this. And setting of these standards and sharing of best practices is actually very particular to each individual area. We did start working with some groups. So, for example, neuroscience is one such area where there isn't a lot of difficulty in sharing the data. People who work in the neuroscience area, they're more open to sharing the data publicly as opposed to, let's say, clinicians and healthcare providers, because there are issues of patient privacy and so on. So we started work in some domains where there are no serious impediments to sharing the data, and then trying to see what we can do there. There are also societies like the IEEE and ACM, which are taking leadership role in this, and we are collaboratively working with them in terms of targeting specific area needs.
Other questions?
Mike. Okay. Question for Dr. Aluru. There are many social scientists who are very interested in big data and would certainly like to have opportunities to delve into using big data to address larger societal issues. It seems, in fact, like the future of the social sciences. And I'm wondering if you see, what do you see as the role of the social sciences in something like the big data hubs and spokes?
Thank you for that question. I think that it's very important to engage social scientists, and although such engagement is happening at some level, I think it's far short of where it should be. So one way the hubs can help address this question is that if you please join your hub based on the region that you reside in, and every hub has mechanisms for new members joining, and just let them know, like for example, for the South Hub, when you join, there is a short statement that you could make. And so if you can make a statement saying that I'm a social scientist looking for relevant collaborations, what it allows is that it allows us to build a directory of expertise and then help do matchmaking. Because we have the same question on the other side, where there may be a technology-oriented proposal that is being developed, but then they would like to have people on the team who can address issues like what are the questions that one should actually be asking with this technology. And I think, briefly during the introductory comments, this issue of machines being biased mentioned. And I was at an NSF meeting recently where this issue was discussed in depth. And this is a big issue where very little research is done, and we are only realizing the problem now through high-profile goof-ups like the Microsoft incident and so on. So keep in mind that one of the interesting things about machines is that they don't recognize bias in the sense that, let's say, for example, take the area of medicine, right? So historically, a lot of the medical tests were done on male population, particularly white males, and because men's biological systems are simpler than women. But you do need to study women, and you do need to study other ethnic populations and so on. A human being, even though they're all looking at all data from one ethnicity and one gender, will quickly realize that we are missing other things. But for a machine, if all the examples it sees are this variety, then it assumes that this is the right thing to do. And it gets trained to that purpose. So in some sense, biases are actually a lot more easy for the machine algorithms than it is for humans. At least we quickly recognize the problem from absence of data, whereas they would only, for them, the data is the world. And therefore, they really fail to recognize that there is even a problem, and they perpetuate it to the fullest extent. So there is a lot of importance for involving folks. And one of the things that we can do is if you just help us build a database, then we can try to do matchmaking. And then we can try to get more of them involved. Certainly, NSF is very, very interested in bringing the two sides together.
There's another question on this side.
Yes, I had a question for Ms. Davis about the slide you had about the metric fatigue, and how you went about deciding on what to narrow that down to and what got lost because of what you limited the metrics that you're focusing on.
Sure. Actually, we had a really long list that Professor Eckert from Virginia Tech helped us with initially, and we had to go through and kind of cull it down. So the way the decisions were made were generally, is this something that we can measure? Is it something that the data exists for? Is it something that is a good proxy for a number of different things? Is the measure something that's going to, like I said, evoke an emotional response, and someone's instantly going to recognize and know what it is? Like, for example, for the equity one, there's the Gini coefficient that I think a lot of people are familiar with. But to a regular person, if this is something that we want the community at large to kind of really kind of feel like they understand what equity is, the Gini coefficient, it requires a lot of explaining. So instead, we're using the measure around the education one. The education, the income you have by education by race. So you can see that if you are African American with a PhD, you earn less money than someone who is white or Asian with a PhD. And so that is something that instantly someone can understand and can feel something about, oh, wow, I didn't know that, so versus the Gini coefficient.
So to follow on your example, it seems like when you created the measures, can you talk a little about governance and who owns the data? Your example in Kansas about the measures disappearing.
Yep.
So when you create high stakes measures that are useful, they're subject to manipulation and control from, you can imagine at this end, it's the end product that disappears. But you can imagine other parts of manipulation about knowing what goes into the big data and having manipulation there. I mean, the U.S. News and World Reports on school rankings, easily manipulated. So can you talk a little bit about your concerns, maybe even creating an independent board that runs and controls these measures? And then also, I just as an interest of my own, you didn't seem to have like crime and safety as a measure.
Yeah.
So is that one? So again, it's not just collecting this information, but it's the picture you want to portray for Fairfax County.
Right.
And by leaving out certain measures, they may be key to certain stakeholders.
No, that's a good point. So first on the governance piece, it's the thing is we keep having to remind ourselves is that it actually is a changing, fluid thing. Because there is a political influence, the measures really could change from year to year based on what is happening, what's hot. Like a few years ago, it was all about sustainability. You don't hear as much about sustainability now; it's all about equity. But so how do you find the balance of you still you need the sustainability, still important. But we do have a commission, an economic advisory commission that has outside folks on it, and hopefully that's going to keep us honest. So it's not just the politicians who are making the decision and manipulating. I don't want this measure. This is not a good measure. This doesn't make us look good. because those conversations happen all the time. Like, I don't want, or there's the accountability measure. Internally within staff, the Department of Transportation director may not want a certain measure because he doesn't control VDOT dollars, or, or there's stuff that goes on the outside. And the crime, that's a good point. There's certain measures that we overlook because everything looks good, because Fairfax is doing so well. I mean, those goals of the plan are things that we think we need to focus on in the next 5 to 10 years. Crime hasn't been an issue. Fairfax actually looks amazing. And it's really kind of a testament to how well we're doing, that when we talk about the equity issue, how many other cities and towns and jurisdictions in this country are dealing with the issue, the police and crime issue, and the inequality, and it's not even part of our conversation. And it's like, what, we really should highlight that, because because just because something is good doesn't mean we shouldn't measure it.
Michelle, I want to throw a question in for you. You had 2 very different case studies. One was the nurses monitoring from afar. One was set in Uganda. It seems like they're on opposite ends of the technological spectrum, possibly. Right. What was similar about the big data ethical challenges those 2 groups were facing?
So I think the biggest issue is who's responsible, who is actually accountable and has the authority to collect data, and how is that data done. So I forgot to put this in a slide, but there's a website that's available to everyone called Hospital Compare, and it's public facing. But very often, clinicians have no idea how that data is collected, how that data is reported, how those variables were selected. But their data, the outcomes of what they do, are presented to the public, that the public then makes decisions on. And so, just to his question about, okay, how do we control what gets into those databases? And I think there's a big disconnect between what workflow and what practices are done, how they're tracked, and how that's reported to the public. And in those 2 situations, similar things kind of occur. There's very little transparent connection made between how the data is collected and how the data is reported and used, I should say.
My question also is for Dr. Rogers, and it comes down to the question of cultural norms. In my estimation, because of your point about how and what data is collected, why it's collected, when it's collected, and the example that was just given between those 2 locations, continue up on that, it would appear that the cultural norms really have a weight to the what, when, where, and how of data. Why one organization or healthcare entity may choose to collaborate, and how they choose to collaborate, what they choose to collaborate on, those kinds of things. So can you speak more about the impact of cultural norms on the ability and the desire even to collaborate?
So one of the other investigators that went with us, her area of research, her name is Deborah Turner. She does a lot on oral documents. And one of the things that she observed, and the reason actually that she went with us to Uganda, was that there is a prevalence and a strong cultural affinity for oral documents, and to use the oral as communication tool to get things done. So we actually observed health camps going on, and the amount of oral communication far exceeded what was documented, physically, and how that documentation then gets perpetrated up through the system. So there are things that are reported to the Ministry of Health and subsequent ministerial offices and responsibility. But what gets documented versus what is actually used by clinicians are different, right? So the fact that historical or longitudinal data is not collected for clinical use has something to say about what does get documented and what gets sent up to the Ministry of Health. And we were able to see how, even if you compare that to an inner city similar like Philadelphia, that has actually a very similar birth pediatric, or I should say infant mortality rate, that what gets documented, how it gets documented, are driven by totally different things. And it's not, without making those connections, it's really hard to see that those are the differences. And it's not just a technology issue. It's somebody makes a choice. What gets documented, what gets sent up, what is considered important to actually document.
So we're at the top of the hour, Susan. How should we proceed from here?
I think maybe one very last question, but we can continue conversations over finishing the breakfast, and which we encourage you to do because lunch is coming. So please feel free to help yourself to the remainder trees. But maybe one quick question, and then we can.
So maybe we'll our respondent ask one final question.
It's not a question, actually. It's a comment on the Uganda issue. I wish I could remember the name of the person who gave the paper, but I saw a paper at the Social Studies of Science conference 3-4 years ago by an anthropologist who'd been studying the execution of a clinical trial in Uganda. And what she found was that the people were doing these home visits, and they were supposed to include and exclude people in the clinical trial according to certain criteria. Did they have certain disease criteria that would include them in the clinical trial? Did they keep taking the medication so that they would be in it? And she found that certain people should have been excluded from the trial, but she was concerned that it might be in some cases a death sentence. And so although they fell outside the formal criteria, she kept them in because she didn't want to hurt them physically. And so it messed up the collection of the data. People who shouldn't have been in the study were in it, right?
So with that, I want to thank all the panelists for the discussion today, the good questions from the audience, and turn it back over to you.
Eat. We will reconvene at 11:15 for our keynote speaker. So please come back here after you've refreshed yourself.
Actually, I was electrical engineering, but I chose to leave it.
Well, the knowledge remains, right? It's not going to go anywhere.
It's not going to go anywhere. Yes, you get those physics flashbacks every once in a while, but try to stay away from that. But know the innovation they're going to be seeing all of that and the expansion. Wonderful.
I'm glad we're off to a lively start. It's so wonderful to have everyone together and talking and questioning and sharing ideas. So it is absolutely my honor to introduce our keynote speaker, Dr. Ana Diaz-Rue. She is a joint degree holder. She has her MD from the University of Buenos Aires and her Department of Health Policy and Management from Johns Hopkins. I have to take my glasses off because I haven't learned how to use progressives yet. I may be one of those people who can't learn, which is very depressing to me. I did not imagine myself as that person. So Dr. Diaz-Rue was originally trained as a pediatrician in Argentina, and afterwards she completed her public health training at Johns Hopkins, as I noted. She has served on the faculties of Columbia University and the University of Michigan, where she was chair of the Department of Epidemiology and director of the Center for Social Epidemiology and Population Health. In 2014, she joined Drexel University as the Dean and Distinguished University Professor of Epidemiology in the Dornsife School of Public Health. And I have to say, she's really been shaking things up and hiring a cadre of faculty who study urban health and health disparities and training the next generation of students to really engage and think about these issues. Her list of accomplishments is quite extraordinary, so I'm only going to mention a few, but she has been a member of the MacArthur Network on Socioeconomic Factors in Health and was co-director of the Network on Inequality, Complexity, and Health. She's been awarded the Wade Hampton Frost Award for her contributions to public health by the American Public Health Association, and she's an elected member of the American Epidemiological Society and the Academy of Behavioral Medicine Research. She was also elected to the Institute of Medicine at the National Academy of Sciences in 2009. In particular, Dr. Diaz-Rue has served on the Institute of Medicine's committee that developed recommendations for psychosocial vital signs. So as we've been talking about already this morning, it really matters what data goes into big data. And if that data is not good or doesn't cover the kinds of things we want, then it's going to be downhill at every step of the way. And so she's really led our nation in many ways of thinking about what is in an electronic health record. Is that the data we need? And if not, how do we do it differently? So her talk today is called Including Measures of Social and Behavioral Factors in Electronic Health Records, Challenges and Opportunities for Research and Clinical Practice. Please join me in welcoming Dr. Diaz-Rue to the stage.
Get this on. Can you hear me okay? Yes. Thank you very much, Kelly, for that very generous introduction, and thank you to the organizers for inviting me. This looks like it's a really interesting meeting, and I'm sorry I can't stay for all of it. So what I thought I would do is give a little bit of an overview of the incorporation of social and behavioral factors in electronic health records, why we might want to do this, what some of the opportunities are, and what some of the challenges are. And I hope you'll see this as an example, I think, of big data in some way, and I think some of the issues that people were talking about this morning, I'm sure will arise as we think about this concrete application. So I thought I would start out by telling you a little bit about, reviewing a little bit, well, what is population health? Because I think this is really critically important in terms of thinking, in terms of the motivation for including these kinds of measures in electronic health records and what we might do with them. And then I want to talk about, well, what's the link between electronic health records and population health? Why social and behavioral factors in electronic health records? And then challenges and opportunities. So there's been a lot of talk about population health recently. You'll see this word a lot more than you used to. And here are a couple of definitions: the health outcomes of a group of individuals, including the distribution of such outcomes within the group, and includes health outcomes, patterns of health determinants, and policies and interventions that link these two. So this is critical because we're not talking here about, important as they are, we're not talking only about individual patients. We're talking about populations and patterns of populations of health and disease. And this is important because it brings in a whole other set of factors that we need to think about if we want to understand population health patterns. This is another definition, a conceptual framework, and this is interesting because it's an approach. Population health can be thought of as an approach for thinking about why some populations are healthier than others, as well as the policy development, research agenda, and resource allocation that flows from this framework. So some critical, the critical idea behind population health is that there are all these factors at different levels that range from the traditional focus of the biomedical world here at the bottom left, all the way to the way things in society are organized that affect health. And so some critical elements of this population health approach have to do with this idea of factors at multiple levels of organization, cells to society, and this raises a number of methodologic issues, a number of analytical issues, things that have to do with thinking about systems and complex systems as opposed to just the traditional reductionist approach of the biomedical world. Integration of social and biological factors. The social world affects biology in very measurable ways. Concern with health inequities is also critical because population health patterns are often driven by big inequalities in health by things like income, race, place of residence, et cetera. So big concern with health inequities. And a corollary of all this is that the healthcare system interventions, important as they are for many conditions, are not enough to really shift these population patterns of disease. So we really need to be thinking about actions outside of the healthcare system, social policy, economic policy, education policy, urban planning policy as critical to health. So now you start to see, well, why we might want to include some additional information in an electronic health record. So this term population health has really picked up a lot, even in the medical world, which is quite interesting to us in public health. We've been talking about population health forever because public health is population health. But you'll see lots, if you do a search for population health, you'll find tons of websites that talk about population health management from the point of view of the purely medical approach, which is important, but it's mostly, in some ways, it's a rather narrow view of population health because it's about managing panels of patients, and it's mostly about increasing the cost effectiveness of interventions, saving money, using resources efficiently, which is very important, but it's not always broadening the vision to include factors outside the healthcare world and think about how those factors might be affecting the performance of the healthcare system and the outcomes of the healthcare system. So why has the medical world become interested in population health? Well, first of all, because many of you may know, there's been a movement towards value-based payment systems, and this means that providers get paid according to their performance, and their performance is affected by many characteristics of their patients that are outside of the traditional clinical realm. They're affected by the social, economic circumstances of the patients, by the neighborhoods that they live in, by the levels of social support that they have. And so all of a sudden, these factors have become incredibly important to think about because they are affecting providers' ability to achieve the targets based on which they are compensated. So this is a big issue. The second is the Affordable Care Act has stimulated the creation of affordable care organizations to incentivize providers to take responsibility for population health outcomes. So now some of them are not only responsible for their individual patients, they're also have at least the beginning of some responsibility over populations. And of course, this means that they need to consider these other factors. And nonprofit hospitals, for example, by law, are now required to do something that's called community health needs assessment. So they have to provide information on the health conditions in their, quote, communities and even develop plans for what they're going to do. So, which has been very interesting. Now, what about public health? Why has the public health world become interested in electronic health records? And there are good reasons here, too. First of all, because of the surveillance potential. In public health, a big part of our job is to do surveillance and monitoring. And although we have good data in many ways, potentially electronic health records could provide another very rich set of information that we could use for surveillance purposes that might be more cost-effective than doing regular surveys, for example. There's also incredible research potential. I'll talk a little bit more about this, using electronic health records. and also policy evaluation. So one of the big challenges in public health is building the evidence base for the impact of policies, often policies that are outside the healthcare system. So for example, Philadelphia has recently adopted a soda tax. So what's the impact of that soda tax on health behaviors, on health conditions? Well, it's really hard to evaluate that because unless we really planned a study before, collected data before, and then collect data afterwards, it's really difficult to evaluate these policy initiatives. But if we had a systematic way of collecting health data that's ongoing all the time, we could use those data sources to evaluate the health impact of a range of policies and things that we're doing all the time that might have measurable health impacts that we don't really know about. And if we could look at those, we could determine create an evidence base for these policy actions. So potentially really important for policy evaluation. So let me show you some examples of how people have already used electronic health records for surveillance for these three things. So for surveillance, this is a paper published a couple of years ago that contrasted influenza. I think it's influenza. It's so tiny I can't. So national influenza rates using a traditional surveillance system and using electronic health records, and you can see that there's a pretty nice match. This is another example, also a relatively recent paper, showing the feasibility of combining electronic health records across multiple institutions to assess trends in childhood obesity. And in fact, the results that they got in terms of estimates of childhood obesity were very much aligned with the estimates from NHANES, which is a national survey done by the National Center for Health Statistics regularly to monitor health trends in the nation. Here's another example, research, and I'll come back to this example later, but this is a paper looking at the impact of various community-level factors, including things like access to healthy foods, on obesity. And it was done using electronic health records. This is more of a research approach, and I'll show you, I want to talk a little bit more about this paper towards the end as another example. And here's just an example of how this kind of information could be used for policy evaluation. I apologize, this is a little small. I can't even see it on my screen here. But so this is looking at hemoglobin A1C, which is a marker of diabetes and diabetes control. And so the data, this is using electronic health records. They were able to estimate levels of HbA1c in this population over time. And there was a period when there was an airing of a public service announcement about the importance of controlling your diabetes. So this kind of data could be used to evaluate the impact of an intervention like this. In this case, at least from this very limited, one time series, doesn't look like there was much of an impact, which is, useful information to know as well. So why do we need measures of social and behavioral factors specifically in electronic health records? Well, the first thing, going back to this picture that I showed you, if we think that there are all these factors outside, that are not traditionally part of the health record that are important, then obviously there's relevance to including at least some of this information in electronic health records if we want to use them for other purposes, or even if we want to improve their use for clinical decision making. So there's a large literature linking social and behavioral determinants to health outcomes. There's very limited data on social and behavioral determinants available linked to patient records for research or for practice. Even standard behavioral information, like whether the patient smokes or not, is that often collected in a completely unstandardized way, difficult to systematically analyze, et cetera. As I said, the reimbursement policies that reward population health management are encouraging attention to the social determinants of health because they are so critical to achieving these goals. And electronic health records could allow users to obtain and store digitized information on standard measures of social and behavioral determinants and make it accessible to clinicians, to patients, to health systems, and to researchers. And we're going to talk a little bit about why this might be useful. So what are some potential benefits to clinical practice of having this information? Because of course, there's no way this information is going to be collected in the context of the healthcare system if there's not some relevance to clinical practice. because obviously this can be time consuming. It creates a series of logistical issues. So there has to be some relevance to clinical practice. And there's a potential that this information could help clinicians in terms of in diagnoses, greater precision in diagnoses, and improved treatment and targeting of treatment, because there are certain circumstances in which knowing some of these factors could help the clinician hone in on a diagnosis, or even tailor a treatment potentially because of awareness of the patient's social context. I mean, this is done informally to a certain extent. Good doctors, I think, do this informally, but doing it more systematically could be helpful. More effective shared decision-making with the patient, because the clinician would have additional information on the patient's circumstances. Identify important risk factors that need to be addressed. So a systematic collection of behavioral factors, including things like depression, for example, could also help address factors that might not, because doctors are overburdened often and are in a hurry and have a limited time to see each patient. They may not be focusing on all of these factors. It could, and there are studies that have started to look at the impact of this, could trigger systematic referrals to social services, community agencies, or to public health that could enhance the effectiveness of the traditional clinical intervention. And also this idea of tailoring and targeting of services, which I was talking about before. And there are actually some groups that are doing studies to determine, well, does it help? Does it actually improve patient outcomes if you have this information available systematically, and you, just like you write a prescription for a drug, you write a prescription for social service intervention, for example, in a systematic way. What are some benefits to public health? Well, enhanced surveillance, as I said, improved etiologic research on population health and health disparities, because it would open up a whole range of data that we could use to look at drivers of population health patterns and changes in population health over time. And as I said, this idea of policy evaluation. So, the benefits are to treatment, to population management, and also to research and discovery. So motivated in part by these ideas, the Institute of Medicine, now the National Academy of Medicine, because they changed their name, convened a committee it was sponsored in part by NIH and other agencies to look into this issue of capturing social and behavioral domains in electronic health records. And it was an interdisciplinary committee that had physicians, epidemiologists like myself, and also people from health informatics and the computer science world, especially people focused on on the whole issue of informatics in the context of healthcare. And this is the charge to the committee: identify domains for consideration by the Office of National, by ONC for Stage 3 meaningful use. Some of you may have heard about this. It's a series of mechanisms to require or incentivize providers to include certain measures in electronic health records in a systematic way. So determine the criteria for selection of the measures, identify domains and measures for inclusion in all electronic health records, consider the implications of incorporating these recommended measures, and identify issues and linking to other data systems. So I'm going to tell you, a little bit about what the committee did. So there are the committee, we issued 2 reports, a first phase report and a second phase report. The first phase was mostly about selecting the domains that we thought were of interest. And the second was more about some of the practical issues and a sort of summary. So the committee the first step was really to identify a conceptual framework that could be used to guide the selection of these measures. And that picture that I showed you with the levels was an example of one of the frameworks that we looked at. And the critical thing is that these frameworks really were broad and looked at both what are called sort of upstream and downstream determinants, in the sense of going all the way from social context to behaviors and individual level characteristics. And we identified 5 levels of interest: sociodemographic, psychological, behavioral, social relationships and living conditions, and also the physical and social environment of communities as levels of interest. for measurement and incorporation. And then we developed some criteria to determine which measures would be proposed, because if you start to think about it, it's incredibly broad in terms of the kinds of things that one could measure and the instruments that one could use to measure them. So we first did a first screening using information on strength and usefulness. Strength means the strength of the empirical evidence of the strength of the relationship between the factor and health. Usefulness meant usefulness for in 3 domains. Usefulness to the clinician, to the potentially to the clinical encounter, usefulness for population health, and usefulness for research. There was a general committee consensus kind of assessment of how useful the measure might be, integrating those 3 uses. In the next stage, once we had determined which measures sort of passed those first 2 criteria of strength and usefulness, then we which domains passed those 2 criteria. We started to look into specific measures, and the second set of criteria had to do with the presence of a reliable and valid measure, and also the feasibility issues. Was it even feasible to collect this information? Because if it's at scale with 30 items, it's just not going to be feasible. And then in the third stage, we assessed the final screening had to do with sensitivity, whether the measure was sensitivity in the sense of whether the measure was a sensitive measure, and it would there would have been the patient would have been uncomfortable providing this information, or the issues around sensitivity, patient sensitivity, and also whether the measure was accessible from some other data source that could be linked, and therefore we didn't want to spend time in the medical encounter asking the patient or having the health provider collect that information. So this is kind of the process the committee followed. So we had this conceptual framework. We identified these 5 levels. Then within these levels, we identified a number of domains, which after applying the criteria of strength of association and usefulness were narrowed down to 17 domains. Then we went into the measures, those 17 domains. There were 31 potential measures of those 17 domains. And then finally, we applied this criteria of usefulness and readiness, whether the feasibility kind of criteria, and ended up with 11 domains and 12 proposed measures. So these were the 5 domains that I mentioned to you: sociodemographic characteristics, psychological characteristics, behavioral, social relationships and living conditions, and then neighborhood and community characteristics. And the in white are the sort of the 17 potential measures that moved past the screening process that we had. And then we identified from that set of 17, we identified some that were sort of ready for prime time. And those are the ones that were called recommended by the committee, and some that were, of importance. The committee thought they were important, but they were not ready for implementation for a variety of different reasons. And this is a list here of the 11 recommended measures, which I'll read them out to you because you probably can't see them. They have to do with race and or ethnicity, which is on this list because it's not collected systematically by all electronic health records. It's asked in many different ways. And so just making that systematic, collecting it using a similar approach across all providers is critical if we want to use this data. Education, financial resource strain kind of measures, a very simple measure of stress, a simple measure of depression, physical activity, tobacco use, which again, although it's present in many medical records, it's not systematic. The same thing for alcohol. Social connections or isolation, intimate partner violence, and residential address for geocoding and linkage to other geographic data. And I'll talk a little bit more about that because I think that's something that has a lot of potential utility. The committee also thought about implementation issues. So just going back to this for a minute, these are the measures that were recommended by the committee at the time. I'm not sure that they are the only ones or the ones that a slightly different committee would have come up with. So I wouldn't necessarily take this as gospel. It's an exam. We went through a process and this is what we came up with. But even within the committee, there were obviously discussions about and not always unanimous agreement on these measures because it's a hard thing to do. But it's just to give you a sense. So the committee also discussed implementation issues, and of course, one critical implementation issue is that many of these measures are self-reported by the patients, and that means that they need to be collected, and that creates complexities. A second issue has to do with issues of privacy and confidentiality, and whether the patient is comfortable having this information on their financial conditions and on their record or not. The other issues are linking, if we want to link this to other data, are there, what permissions do we have to have in order to do that? And of course, resource considerations in a very, in a healthcare system that is often struggling, what kinds of resources and time are going to be needed to collect this data in a way that is useful. So, I also, let's suppose that we were able to collect some of this data or incorporate some of this data in a systematic way. What are some of the opportunities that this would present? And one of the recommendations of the committee was that, as you see here, was the importance of standardized data collection. So this idea that standardized data collection and measurement are critical, and most of these data, currently EHR vendors and product developers lack harmonized standards to capture such domains and measures. So there's really, if we are going to take this seriously, there's a need for thinking about data, research into how to collect this data and how to harmonize this data, how to combine this data. And so there's issues in terms of the methods that we would use to collect this data. What kinds of surveys, when would these surveys be asked, who would administer them, et cetera. What kind of measures, the committee recommended some, but there's tons of work to do in terms of thinking about what the most useful measures might be. Are there cutoffs that a clinician would use as a screening tool? How do we determine what those cutoffs should be? Acceptability to patients and to providers. This is also, I think, a really big deal. And then the ethics of having this information available. What kind of, could it raise, could raise issues of stereotyping? We know, for example, that there are, challenges in healthcare in terms of implicit bias and stereotyping, and would having some of the social information maybe cause more of that as opposed to less of that. So not benefit the patient, but potentially harm the patient because of assumptions about what certain patients can and cannot do. And so this is all an area that is ripe for research, really. This is an example. This is a very recent paper. It's a very simple study, but it came out just, which basically was just trying out a series of questions, some of the domains recommended by the committee actually, and administering them in different order to different sets of patients and seeing whether the responses were kind of similar. So a very simple thing, but yet an important thing in terms of thinking about data collection. So there's lots to be done in terms of how this data is collected and in a way so that it will be useful. Another big area has to do with data linkages, and particularly in the geographic realm. So there's been a discussion for a long time. This paper is several years old now. About the potential utility of linking all healthcare data to geographic data. This is one example, this idea that this geographic health information could support the triple aim of the healthcare system. This is another example. This is taken from Duke, from initiative in Duke they call geomedicine, which is really interesting to me, because to me it's just public health, not geomedicine, but where linking electronic health records to geographic data in a very systematic way across the whole system and all the ways in which this could be used. And so, why would we want to do this? Well, there's a lot that one can get from geographic data. This is an example of a paper that we did many years ago now, but the basic point is that knowing a simple socioeconomic index of the patient's neighborhood is strongly predictive of their risk of coronary heart disease, for example, even after you control for other factors. And even among patients who have a heart attack, for example, the prognosis, their mortality risk after a heart attack, is also strongly predicted by the socioeconomic characteristics of their census tract, even after you account for a whole bunch of clinical risk factors that we know are really important that have to do with the severity of the MI, et cetera. And in fact, there have been studies looking specifically at CVD risk prediction. This is a paper looking at, some of you may be familiar with the Framingham risk score. It's a very utilized risk score to predict risk of cardiovascular disease. And what this paper showed was that adding a socioeconomic indicator derived from the participants' residence added very important information, additional information to the risk prediction. And in fact, they concluded that, that in fact this could have changed treatment decisions if the physician had had this information available, because patients would have been classified differently in terms of their risk and therefore would have received different treatments. This is another example, not related to cardiovascular disease, but looking at census tract socioeconomic status as a determinant of colorectal cancer outcomes. So there's a potential for a lot of utility of even a very simple census-based measure of SCS as an additional variable in risk prediction in medical records. Of course, you can also do mapping. This is an example of a study that used electronic health records to map the location of vaccine completion and burn cases, which is really interesting. Among children, burns are a major health issue, but you can actually map and see, using electronic health records, where are the hotspots of burns, for example, of childhood burns in a particular area, and think about what kinds of interventions could be used. And this is another example, also from a paper that used electronic health records to map diabetes across various neighborhoods. So given that providers are now, as I said before, increasingly incentivized to think about the health of their communities and management of population health in their areas, this kind of information in terms of mapping can be, simple mapping can be very helpful also. Now, of course, in addition to census data and mapping, there's tons of other geographic data that could be linked to these records. Things related, for example, to access to resources, healthy foods, recreational facilities, sorry for the typos there, health services, built environment, land use, walkability, access to public transportation, which has been linked to the use of healthcare and et cetera. Air pollution, traffic, other environmental exposures that we know are relevant to health outcomes, and also things related to social context, residential segregation, violence, social cohesion, as factors that may be important not only in the development of certain health conditions, but also in the patient's response to treatment that they get from their providers. And this is that paper that I showed you earlier, looking at using electronic health records to look at community-level factors in relation to body mass index. And it was a very large study. They had tens of thousands of electronic health records, and they basically created all these measures using zip codes, which isn't ideal. You can do much better than that, but that's a start. And then they were able to quantify, both map out the availability, in this case, of healthy foods and the obesity rates in their community, and also estimate the associations between these factors and obesity risk. So these are just some examples of things that one could do, but there's also a lot of research to do in this area. And the first, because if we wanted to do this systematically, there are lots of issues. that we need to address. The first is that, geocoding is not a trivial thing if you want to do it right. And so thinking about, how would you systematically geocode all electronic health records? How could you do that in a way that yields reliable geocodes? Quality of addresses is really important. Patients are moving. How do you keep track of where they are, et cetera? So a whole bunch of informatics issues that need to be addressed to do this properly. How do you link to the census data? That's not that hard, but there are complexities. Some of you may know the census now, particularly for the socioeconomic kinds of things that we're interested in, the American Community Survey now does samples, so we'd have to pool across multiple years to create the measures so that they're reliable, so that there's some issues there as well. How could we do this? How could we create the informatics systems that would allow us to do this systematically? And then the whole links to other area level variables. Increasingly, there's more and more data available georeferenced, but we need to make sense of that data. It's not a question of just linking to everything. We need to think about how we can create meaningful measures from that information, and that's not a trivial task. And then, of course, issues of confidentiality, right? If you do this linkage, you need to have exactly where the person lives. Well, how do you strip those? You need to strip those identifiers later, potentially. If you had lots of area level measures, you could potentially identify the person, although I think that's probably, the concern over that, I think, may be a little bit exaggerated, but nevertheless, there are confidentiality issues. There are also opportunities, lots of opportunities for research in terms of how we collect and process this data, but also lots of opportunities for research in terms of, well, how useful is having these social and behavioral measures in electronic health records? Are these things that we talked about, utility to providers, utility to public health, are they real? Can we document that it really makes a difference? And the committee also had recommendations on advancing research and the Office of Behavioral and Social Science Research coordinating this plan. I don't know that happened, but it's a recommendation. So what is the added value in clinical practice? And that's an empirical question. What's the added value in diagnosis, in specific cases, in treatment decisions, in prognosis and risk prediction, in follow-up plans? Could this information be used to determine how frequently a certain condition needs to be followed up? This idea of, do these referrals and complementary interventions, do they really make a difference? Do patients do better when they get referral to social services under certain circumstances? These are all empirical questions that have not been answered. And then, the issue of utility, public health research. Well, first, of course, to use this kind of information in things like surveillance, we need to have confidence that this information is valid and reliable. And we're starting to see some of that. I showed you that influenza figure that was pretty similar, suggests that this information is pretty valid, but there's a lot more to do there. These are a whole bunch of other research areas in which this information could be used, including, I put here at the bottom, what's the patient, this is a more qualitative question, I think, how does this change the patient experience, having this information, having somebody ask this information, how does it change the nature of the medical encounter, and what's the implication of that? And all of this is critical to this whole precision medicine initiative that some of you may have heard about, and I'm happy to talk more about, because if we want to do precision medicine, we need precision in the genetic stuff, yes, but we also need precision in the environmental stuff, and perhaps even more than in the genetic stuff. So this is really critical to that. So to conclude, I think this is an area which is, really, it's fascinating to me at least, because it really integrates clinical practice, informatics, public health, social science, and communities and patients. And so I think there's a lot of potential. It's challenging, and there's a lot to do and a lot to think about. So that's all I had, and I'm happy to take any questions or comments. Yeah.
Let me see if I can get this to work. I'm Suzanne Thomas from Intel Labs, and I'm struck in your talk today and the talks we had earlier today, this element of the time scale of data and the longevity and the timeliness of data. And I was curious, when you're thinking about these electronic health record measures, what are the life cycles or the lifetimes of these measures? And how do you imagine them evolving as they borrow and lean on data sources that have other life cycles and lifetimes?
When you say the measures, are you referring specifically to these social and behavioral measures?
I was thinking of the list that you had there. Yes.
Well, the committee talked quite a bit about that. I mean, some of those measures would have to be updated in a regular fashion because they change, right? Yeah. So there would have to be, for them to be useful, there would have to be a system by which they're periodically updated.
Right.
That would have to be built into the data collection mechanism.
How do you imagine they might evolve over time? And here I'm thinking in histories.
Yeah. Evolve over time in terms of...
What is measured? Do they change over time? Or,
they definitely could. I mean, this list, as I said, this is a preliminary list that was developed by this committee at this point in time. But I think certainly the kinds of things that one might think are important could change over time, and there could be a process, just like there's a process to evaluate what's in the electronic health record. You know, there are committees that meet periodically to determine what should be in there. This should be integrated into that process so that the information that we're collecting is relevant, timely and relevant to the things that we know are important or useful. So this would have to evolve over time, definitely, this list.
Great, thank you.
Let me turn this on. Hi, I was wondering, what is going on as far as any kind of regulation or policy building about creating a standardized language to use for these different types of, we have so many different applications, right? So many different apps. But we have a difficulty with being able to use the big data sets because when we have to clean the data to decide, you know, what equals what. Is there work towards creating this kind of regulation that then would go out to software developers and designers for this is the language that we're using?
Well, I mean, I'm not sure I'm the right person to answer that question, but in terms of the work of this particular committee and these social and behavioral measures that were recommended, the idea was precisely that they would be collected in a standardized manner and that they would be incorporated into the requirements of Meaningful Use 3, which means that they're collected in a standardized way by everyone, by all electronic health records. You know, the hospitals, other people in here probably know a lot more about this than I do, but there are incentives for them to include these measures in a way that is consistent with a systematic recommendation. Unfortunately, I don't think any of these made it into this last round of meaningful use discussions, but hopefully they'll make them in later. But that is critical because part of the problem now is that, I mean, some of these things are in records, but they're all in different formats and different ways, and so it's really hard to use across multiple institutions. Sorry, I think I'll go here and then I'll go there. Yeah, go ahead.
I'm Barbara Allen from Virginia Tech. I was interested in why, I mean, you mentioned this, but why environmental factors? I mean, you talk about the behavioral and the social factors, but environmental factors can deeply influence public health and chronic kinds of illnesses, as well as triggers for other kinds of illnesses. I mean, I think the bubble should be just as big as the social science bubble, is looking at the environments in which these communities live, because oftentimes you see income or race track poor environments.
You're talking about this figure?
Yeah, and just in general, the talk, I mean, it was like like asthma, for example. I mean, that's
obvious. Absolutely. I mean, public health is about the environment, in my view. So definitely that's critical, yes. The environment broadly understood, the social and the physical environment, which includes all those things, absolutely.
I did. Am I on? Hi, I'm Linda Mann. I have a question. I'm really interested in your work with the geolocation and the residential. You suggested the racial segregation and the increase in potential disease. Are you seeing an increase in public policy work as a result of some of your research in this area? And can you speak to that a little bit?
Yeah, it's a good question. I mean, I think, so speaking very specifically from the point of view of my own research, so my research group has focused primarily on the impact of neighborhood context on cardiovascular disease. And we started doing this a long time ago. And when I started out doing it, I really had to explain to people, particularly within the medical world, over and over again, why on earth I was interested in neighborhoods when I was talking about cardiovascular disease, because it's all about the patient and their behaviors and what they choose to do or not choose to do. But interestingly enough, now it's pretty mainstream in many places to talk about the impact of neighborhood or community context. And so I think not only our work, but so a whole body of researchers who've been pushing this idea forward, I think it has influenced the way in which policymakers think about this. So you'll see things like the Fresh Food Financing Initiative, food trucks, fresh food initiatives as an example of attempts to take some of the research that shows that there are these relationships and make some policy changes. The challenge now is to evaluate whether this is working, because one thing is to look at it in an observational context, and another thing is to change it and see, well, what effect does it have, or what kind of change is needed, right? So I would say that there's a lot more attention to these kinds of factors than there used to be in the policy world. At the same time, I think if the dominant, very biomedical paradigm is still very, very strong, and so. And you see this, in my view, you see this in some way reflected in the Precision Medicine Initiative, which is, yes, the statements are that it is also about environmental context, but it's really, really, really about genes. So it's really, there's an attempt to broaden it, which is good, and I think we have to get in there and buttress that, but in the implementation, it's still very individualistic and biomedically oriented. Yes.
Carolyn Hoban. I think this is fascinating, and there's so much depth for research. One is a comment about the structure of data within the electronic health record. Sometimes it's often missed about the social or behavioral context in internal medicine. It will be captured in the psych notes, but not in internal medicine. And there you have to go hunting, and it's often a nursing note. And it might only be one line: do you live alone, or do you have family? And sometimes that's the biggest indicator of medication compliance and getting back into the hospital. So there has to be the EHR, standard common data definition, to make this all work. And we can have a voice on that, I think. The other comment is around, I think that the geocoding is fascinating, and it encompasses so many variables, and one of them might be just insurance, and I wonder if you're looking at that. Since Medicaid and Medicare now have such penalties for readmission in 30 days, a lot of those are not happening because of the penalty. And it kind of reflects to the previous question about how you can use this information to reflect an impact on policy changes about equity and to health care.
No, I think that's a very important point. Interestingly enough, I just finished up on another committee which is looking at accounting for social determinants in Medicare value-based payment plans. And this idea of geocoding has come up in that as well. So it's a big issue, Yes.
So I was really interested in alcohol as one of the risk factors you looked at. I did a big project on teenage drinking a few years ago, and the team I worked with, we wrestled a lot with how to try and come up with accurate measures of teenagers' alcohol consumption. So there's a famous study by the anthropologist William Rathje, where he asked people to estimate and report on their alcohol consumption. And then he went through their trash and looked at the beer bottles and the wine bottles, and there was an enormous discrepancy, and it was always in the same direction, that people underreported the consumption of alcohol. And if someone has a real alcohol problem, if they're an alcoholic, alcoholics are notoriously in denial. They may well not report accurately how much they're drinking because they don't want their doctor or themselves to know that they have a problem. So how confident are you in those alcohol numbers, and how does one become confident?
Yeah, well, there's a lot of research on this topic of how well survey questions perform in assessing behaviors, and alcohol is certainly one of them. The specific questions that the committee recommended, I can't remember, but I think that it's not worth going back. We did a lit review and identified the questions that seemed to perform the best based on, what we knew. Now, is that going to be perfect? No, of course not. And it is self-reported data, and that's one of the challenges. But that's really the best that we can do in that context. Maybe there's a way that we could go through people's trash. Yeah.
Is there any indication that, for example, insurance companies are using this data to determine which markets they want to serve, given the relationship between community and outcomes and payments?
I'm sure that they are. I know that, I've been contacted by insurance companies who are interested in, using geographic data. I believe even Blue Cross Blue Shield has developed a whole geographic initiative. So I can't give you specific examples, but they are very interested in this. So that particularly in even simple things like just looking at census measures, like census socioeconomic characteristics of where their patients are located and whether they could use that, I don't know, perhaps to determine what markets they go into, that I don't know, but also to improve risk prediction in the patients and potentially, risk stratify differently. So they are very interested in this stuff, actually.
Thank you very much. I guess I'm struck by the balance of benefits that you described in your presentation, and then I think questions and your responses have suggested some real risks of thickening the surveillance. And given all your experience, I'm wondering if you have found, because it'll come up across, I'm pretty sure, all of the presentations we have, the risks of thickening the web of information around us, ways to ensure that the actual interests of the population do get served by these thickening webs, like actual measures that you have thought about or recommended to make sure that there's not implicit buy-ins, price discrimination, market closure, the kinds of things that people are worried about.
Yeah, I don't know that I have an answer to that question. I think there are good things that can be done with this data that will benefit patients and people in general. But I also agree with you that there are many risks, and I think one of the challenges is to figure out how to avoid those risks. There are risks now, too, without not using that data. There's implicit bias now all the time, going on in different ways that don't have to do with collecting this data, just the doctor's impression of what the patient looks like, So I think certainly there are risks, but I don't think those risks, in my mind, I think there are ways that we can manage those risks. We have to figure it out, and I think the potential benefits are enough that it's worth going down this path and trying to do it in a way that protects the patients. I'm not sure if that's the best answer, but that's what I can come up with.
So I'm Sally Keller from Virginia Tech, and you haven't really talked much about access to the data. So we know that we've made a lot of progress through meaningful use in the collection and the implementation of electronic health records. We're making some progress between the vendors on interoperability between these systems. But for the researcher, in terms of who has access, what is your feeling for where we are on that trajectory?
I'm not an expert. I haven't worked with electronic health records much yet. We do have a little initiative at Drexel that Edgar actually is part of. I think the access is still very challenging because it's still very challenging because there's not a culture and a tradition of using this for research or for other purposes. And so I think there's a lot to do there. But I think part of it is, as we say, these things, it always as you start to use the data and show that something meaningful can be done with it, then people start to recognize, why it's important for you to have access and come up with ways to give you access. So it's we have to, work gradually to show why this is potentially important and useful, and I think that will help open up ways to get access. Otherwise, just asking for access without, that will never work.
Thank you so much. That was really informative and thought-provoking. And once again, we can continue conversations, this time over lunch. We've got a variety of breakout rooms, and we've got someone to guide us to breakout rooms. But just in case you're looking, we've got the Smithsonian, the McPherson, the Clarendon, the Vienna, and the Farragut West. Those of you who are not from this area, you've just nailed it. But anyway, again, if you go out here, you'll find some lunch and people to guide you to a room. So please, we encourage you to continue conversations about the potential for collaboration.
Excuse me.
And we'll reconvene at 1:30.